So thank you everyone for joining us for day 4 of the Molecular Oncology Society conference. Without wasting any time, I would like to introduce our chairperson, who is none other than Dr. Tapan Saikia, who is a senior medical oncologist from Mumbai. So without wasting any further time, I would like to hand over the mic to Tapan sir. Over to you, sir.
Thank you, Kashish, Dr. Mahajan, and all the organizers. I'm grateful for inviting me to chair these sessions. And today is the day for hematology, day 4 of MOSCON, and seems to be some exciting topics here. And the speakers also, I'm familiar with the speakers, not met some of them personally, but it'll be very exciting to hear this whole session on hematologic malignancies. So the first session today is on B-cell malignancies. So there will be 3 talks, then followed by a session and panel discussion moderated by Dr. Pankaj Malhotra, our friend from Chandigarh. He will introduce the speakers then. My job will be to introduce the speakers. The first speaker, Dr. Nilesh Vasekar from Nasik, hematologist, know him personally. Dr. Anil Iram, hematologist from Imphal, and Dr. H.S. Darling, medical oncologist from Arm. Welcome to you all. First talk will be Dr. Nilesh Vasekar on a new molecule in follicular lymphoma, tazemetostat. Dr. Nilesh, please.
Thank you so much, sir, for the introduction. And thank you so much, organizers, for giving me this opportunity to talk about this molecule in follicular lymphoma, new molecule in follicular lymphoma. Tazemetostat, when the organizers asked me to talk about tazemetostat in follicular lymphoma, I was a little bit aware about this molecule, but not that familiar with it. But after going through the literature and all, I think this is a game changer in follicular lymphoma, especially in relapse refractory setting. So coming to follicular lymphoma, though it is low-grade lymphoma, but it is an incurable disease. Western data shows there are 40,000 new patients annually, and 90% of them do get rituximab-based chemotherapy, followed by 80% patients will require second-line therapy, and only 25% of patients will get cure, and 75% will need third-line therapy. So, if I remember my residency days, during those days we used to call it as a good malignancy to have, like follicular lymphoma, mein kuch nahi hoga, don't worry. But now, after seeing second and third relapse, and without having much options, it feels that follicular lymphoma is a tough disease to treat. And if you see baseline mutation analysis, around 20% of patients do have EZH2 mutation. So it is a low-grade lymphoma, easy to treat. Wait and watch policy is also possible. Initial options like bendamustine, rituximab, single-agent rituximab, rituximab plus CVP, R-CHOP, if your disease burden is high, and followed by R maintenance is a pretty standard of care. But what after that? If patient relapses after a BR or R-CHOP or RCVP, or those who are not responding to them. So at relapse setting, we do have lenalidomide plus rituximab after the fantastic results of Augment trial, and we have PI3K inhibitors. But what is the real life data of PI3K inhibitors? Do they have a response rate of around 50 to 60%? But the complications are much more, and the response duration of response is 10 to 12 months only. So do we need anything else in follicular lymphoma? Yes. What about other oral agents which has a success story in CLL, like Brutinib, venetoclax? They have failed badly in follicular lymphoma. So we don't have that option. So what option we have for such cases, relapse refractory cases where we can use something? Yes, we do have now, that is tazemetostat. It is basically developed by Epstein, and the mechanism of action is It inhibits EZH2 gene, which is responsible for transcription of the tumor cells. By inhibiting EZH2 gene, it does cause it does stop the proliferation of cancer cells. It has been used in solid malignancy like epithelial sarcoma and approved for the same. And it was tried in relapsed refractory follicular lymphomas and DLBCL also. So this was a trial, landmark trial of Tisvotostat in relapsed refractory follicular lymphoma. It was open label, single arm, phase 2 trial. They have included 99 patients in that, and 45 patients had EZH2 mutation, while 54 patients were not having EZH2 mutation. Those were wild type EZH2. Those were enrolled in the study. The dose was, it was oral drug, and the dose was 800 milligram per oral BID, continuous 28 days cycle. And you can see the results here. EZH2 mutated as well as wild type. The progression-free survival is at equal in both the groups almost, and overall survival is also equal in both the groups. So 69% of patient in EZH2 mutated group got an overall response of 69%, and while in EZH2 non-EZH2 patients got 34% of overall response rate. So which is a significant one. The CR rate is 12% in EZH2 mutated group and 4% is in non-mutated. So looking at the duration of response, EZH2 mutated type disease had a median duration of response of 10.9 months. And surprisingly, non-EZH2 disease had a response rate of around 13 months, which is slightly better than PI3K inhibitors. What about safety? Coming to safety, very safe drug. Tisvotostat is very safe to take. Only grade 3 or more complications were in the form of thrombocytopenia, neutropenia, and anemia. Serious treatment-related adverse events were reported in 4 patients only, and there were no treatment-related deaths. So, in short, the drug is quite safe to take. These are the other side effects which have been reported in the trial, and these side effects are pretty manageable. So after this landmark trial, FDA had approved the drug for relapsed refractory follicular lymphoma. Those relapsed refractory follicular lymphoma who are having EZH2 positive disease, which is detected by FDA approved test, and those who have received 2 prior systemic therapy. What about other patients? Yes, other patients also where EZH2 is not positive and they do not have any available satisfactory treatment option. At least 2 lines they should have used, and third line, as a third line you can definitely try, because 34% response rate is there for that group of patients. Some exciting data is coming up with combination, because as the side effect profile is very good with Tisvotostat, the new trial is coming up with Tisvotostat and LEN plus rituximab in relapsed refractory follicular lymphoma. They have shared the data of 7 patients who had received it, and out of those 7 patients, 3 got a complete response and 4 got partial response. So in 2023, we'll get the final results of this study. Also, another group is trying Tisvotostat plus rituximab in relapsed refractory setting of follicular lymphoma. So we are waiting for these results of these 2 studies, which will definitely change the landscape of Tisvotostat in the management of relapsed refractory follicular lymphoma. Thank you.
Thank you so much, Nilesh sir. We'll now request our next speaker. Tapan sir, would you like to introduce the next speaker? So our next speaker is Dr. Anil Haram from, he's an hematologist from Imphal.
Well, I'm sorry, Kashish.
No worries, sir.
Kashish,
Yes, sir.
there's enough time, looks like, we have. Can we
Sure,
have
sir.
some questions here then?
Sure, sir. Please go ahead, sir.
The first question is coming from Dr. Abhay Babe in the chat. Is this drugs available in India? Dr. Nilesh, do you have some kind of information?
Actually, we can get it on compassionate basis, but not available. And the cost, I have inquired, the cost will go in the range of, for 1 month therapy will go in the range of 3 to 3.5 lakh rupees.
Okay,
Yes.
okay. Thank you. And then you said about it is 800 milligram twice daily.
Yes, sir.
And any guideline for the dose de-escalation or anything it should be taken after a meal or any relation to food?
Okay.
Any guideline?
Yes, sir. In the trial, they have used it after food, and de-escalation was not given in the trial, sir. So majority of the patients, those 4 patients who developed side effects, the drug was stopped for them.
Okay, no relation with food, right?
No, sir.
Because they're not, no, okay. All right. Any other questions coming up? Let me see. He's asking, Dr. Bhave is asking about the treatment. Is it for infinite time or finite time? Do you have any information on that?
Yes, sir. Yes, sir. They have used it for a period of 12 months and 21 months, 24 months also, and 36 months also. So in the initial results were given after 12 months, and these results are after 36 months of therapy, sir. So the idea is to continue till disease progresses or the patient develops some kind of side effect or complication.
All right. I can't see any further questions from my side also. No other questions to ask. Nilesh, that was a very good review because it's a new drug. We'll be hearing more about it, especially the combinations you have said. And then definitely the follicular lymphoma, those 20% you mentioned have a bad prognosis, and probably someday it will come as the first line of treatment.
Yes.
Any question has come from Dr. Nilesh? Any particular age group?
They have used it, yes, sir. They have used it for those patients above 16 years of age, sir.
60 years. 60.
Yes, sir.
Okay. This is the disease of elderly people.
Yes, sir.
Right. Thank you, Dr. Nilesh. Thanks
Thank
a
you,
lot.
sir. Thank you so much, sir.
So, Kashish, we move on to next presentation then?
Sure, sir.
Yeah. Next speaker is Dr. Anil Haram, from a hematologist from Imphal, Manipur, and he will be speaking on Ecalabrutinib in CLL as a single agent therapy. Dr. Anil, please.
Good morning, everyone. And I especially like to thank the organizers of Mosocon for inviting me to allow me to speak on this new molecule, Ecalabrutinib monotherapy in CLL. And when we already have so many other molecules, so many chemotherapy, why we need this, we will try to understand. So background is simple, that it is a glutathione kinase inhibitor, and we already have one more glutathione kinase inhibitor in the form of ibrutinib. But why there is a need for the second one? The need for the second one is because it is known to have better kinase activity in the vitro, and compared with ibrutinib, it is known to have some decreased side effect, even though there are no head-to-head trials. The various studies like phase 3 Elevate-TN and the Ascend trial have shown that there is a significant improvement in the favorable safety outcome. So because of these safety outcomes, when they compared with the Ecalabrutinib and the control therapy in these particular studies, this Ecalabrutinib has been approved for FDA, approved by FDA for the treatment of treatment-naive as well as refractory and relapse CLL. So these are the following studies which I will be going through today, so that by these three studies, it has proven that Ecalabrutinib monotherapy may be used for the treatment of CLL. So the first study by Zgaya et al., which was presented in ESCO 2020 as an abstract, have shown that definitely the have shown that this one patient group is the Ecalabrutinib. The second is the either Idalizumab or rituximab or bendamustine plus rituximab. We see here that at the end of 18 months, we can see that it is mostly more than 80% are doing well. On the other side is nearly around 50% at the end of around 16 months. On the other side, if you see that in this particular study also, this is BR, the violet, and the green one is Idelalisib and the rituximab. Here also we can see that the response drops down gradually over a period of about 24 months. By 24 months, it drastically differs. So we can see that the p-value is also quite significant. And so definitely it has shown that this molecule is going to really be very helpful. And in this particular study, there was another subtype in which they did the analysis for those who are having P53 mutation, either positive or negative. Whether deletion 17p is positive or negative, it has shown that the hazard ratio is all less than 1, we can see. And again, based on the IGHV mutation status, whether it is mutated or unmutated, it can be used in both of them. And regarding the side effect, in their particular study, the common side effects which has been associated with this particular molecule is atrial fibrillation, then hemorrhage. However, interesting thing is that if it is severe hemorrhage, like life-threatening hemorrhage, more or less it is not different in the Ecalabrutinib or in the other group where the patient receives bendamustine rituximab or rituximab. The other common side effects have hypertension, infection, some other secondary malignancy likewise. So these side effects are quite manageable compared to the other previously immunotherapy, chemotherapies. Then the second study by Mrd, which was published in ESCO 2020 again as abstract number 8024 about the long-term efficacy of Ecalabrutinib, where they have done this particular study on 99 patients. They gave dose of 100 milligram BD in around 60 patients, and around 39 they gave 200 SOD, and the mean year was 64. Deletion P was detected in 10. IGBS unmutated in 62. So basically, they are all high risk people who are not fit for chemotherapy. So median follow-up at end of 53 months, the duration of response and all this 48-month treatment response rate was so good. Almost 97 people were responding properly, and there was a reduce in the lymph node size, as well as the patients with partial response had no lymphocytosis. So coming to the effect here, if you see that in this 48-month overall ratio of event-free survival, almost 90 people have responded, and if you see the CR, complete response is about 7. However, even though most of the patients are not in CR, partial response where the hemoglobin patient doesn't have to require blood transfusion, patient doesn't have to have the thrombocytopenias, all those symptoms, patients are asymptomatic. So it's almost 90% are having partial response. And one more interesting thing they have found is that this in the subgroup analysis again, almost all the patients responded to this treatment. So in their long-term safety data by this particular author, they found that headache is there, diarrhea is there, then some upper respiratory tract infection, arthralgia, and confusion. However, most of the side effects were less than grade 2. And again, in this particular study also, hemorrhage was a concern. However, major hemorrhage is only 4%. Other than that, infection again is seen in this particular infection, but in any other chemotherapy also, these infections are also seen. So it is not going to be a very big issue. So the third study, which I'm going to share, is about the full safety analysis about Ecalabrutinib in B-cell malignancy. It was published in, again, this as an abstract at the ESCO 2020 by Farman et al., where they assessed about 9 clinical trials, including 1,040 patients, and they have followed up more than 26 months, and they have interestingly found that 65 patients continued, which is a good thing. 65 patients out of 1,040 continued on Ecalabrutinib. However, 9% could not continue due to some side effects. And most of the side effects in their study also shows headache, diarrhea, which is seen in most of the other study. However, grade was only 1 or 2. Grade 3 occurred in about 54 patients. Most commonly was anemia, neutropenia, and the pneumonia. So in this particular study, so grade any grade was 66, but grade 3 was 17.3, and the hemorrhage has been already shown by the previous author also. And cardiac problems were there. However, atrial fibrillation was lesser, and it was not a indicator for stopping the drug. And other than this, not much problems. So there also we see that the cumulative incidence of hemorrhage for any grade was 40 above. However, if it is only severe, it was very less. Atrial fibrillation, again, we see that it is quite reasonably less. So to conclude, Ecalabrutinib monotherapy has been confirmed by this particular study, SN3, that previous interim results, and they have demonstrated statistically significant progression-free improvement and favorable safety with Ecalabrutinib versus idelalisib and rituximab versus and BR in case of refractory and relapse CLL, and any T53 mutation or BAC mutation. The long-term safety and efficacy result of this phase 2 ACECL001 study also confirmed that monotherapy leads to durable response and no new safety signal in patients with treatment-naive CLL. And together with the full safety analysis of Ecalabrutinib in B-cell malignancies, this report support favorable tolerability and efficacy of Ecalabrutinib for patients with B-cell malignancies. So all these studies have shown that this Ecalabrutinib has a long way to go, even though there are no head-to-head trial with Ibrutinib, but it is found to have some benefits like decreased bleeding, decrease and complications. So it will be nice to see in future about these two comparisons. Till then, we have a very good molecule in the form of Ecalabrutinib. Thank you.
Thank you, Dr. Anil. That was a very concise presentation. For the sake of time, we'll take only one question from Dr. Wawe. The second one seems to be more important. Is there tumor lysis if the WBC count is very high? Do we need to cytoreduce before using it? Dr. Anil, any information on that?
Am I audible?
Yes.
Tumor lysis has been reported in by authors who have also shown that tumor lysis is a possibility. So if the high counts is there, we can take care of that. However, in case of hyperleukocytosis caused by any other malignancy like acute leukemia, the chance of tumor lysis is more. However, in case of CLL, even though the TLC is very high, the evidence of causing tumor lysis is slightly lesser.
Okay, thank you. An exciting drug. Most probably it will replace Ibrutinib, hopefully, or both will be able to use it. Thank you so much, Dr. Anil, for this presentation. We move on to the third and final presentations. Kashish, we do that?
Yes, sir.
Yeah, that will be by Dr. H.S. Darling from Armed Forces, and he will be presenting the 5-year follow-up report of the Murano trial of using venetoclax and rituximab. Dr. Darling, please.
Yeah, good morning all. Am I audible, sir?
Yes, sir.
Okay. Yes, you are.
First of all, I want to say thank you to the organizers and especially Dr. Manoj and Dr. Randeep Singh for giving me this opportunity to present this abstract So this is an abstract which was presented in ASH 2020, and it is about the Moreno trial, 5-year analysis. It's a phase 3 trial which compares fixed duration venetoclax plus rituximab versus standard of choice, standard of care bendamustine and rituximab in relapsed refractory chronic lymphoid leukemia. So we all know that upfront we have these options, and in a relapsed refractory setting we have same option plus PI3K inhibitors. So we use Bruton apart from the chemoimmunotherapy, which was standard of care a few years back. Now we have so many drugs, and according to the risk we select those. And amongst these are Bruton tyrosine kinase inhibitors, which Brutinib and Ecalabrutinib, which was just discussed. Then BCL2 inhibitor venetoclax, which is a beautiful drug, and then CD20 monoclonal antibodies, 3 of them, rituximab, ofatumumab, and obinutuzumab. Then chemotherapy, fludarabine, pentostatin, and chlorambucil, cyclophosphamide, and bendamustine. In a relapsed refractory setting, we go for the targeted therapy predominantly, which include BTK inhibitors, venetoclax, and newer agents, PI3K inhibitors, idelalisib, and duvelisib. And then again, anti-CD20 monoclonal antibodies. Now, regarding the venetoclax, it's an oral drug, and because of the risk of tumor lysis, we use 5-week ramp-up schedule in relapsed refractory CLL settings. So this is like this over 5 weeks. Now, the background of the study: venetoclax is a highly selective BCL2 inhibitor that has been approved by FDA for treating patients upfront as well as in relapsed refractory CLL. This was the phase 3 Moreno trial, which investigated the efficacy and safety of fixed duration venetoclax and rituximab. Now, these are the only agents where we are talking about the fixed duration, which is very important, as we will be discussing further in the first line setting also, and in the relapsed refractory setting also. In a 4-year analysis, which was presented last year of the Moreno trial, patients receiving venetoclax combination had superior progression-free survival and overall survival versus those receiving standard chemoimmunotherapy, with most of them achieving undetectable MRD, minimal residual disease, at the end of treatment. Current analysis is 1 year further, so it takes 5-year outcomes. So this was the randomization. The patients were randomized equally in 2 arms, 1:1 ratio. They took adult patients with the relapsed refractory chronic lymphoid leukemia with 1 to 3 prior treatment lines. And prior bendamustine was also permitted if it was the duration of response was more than 24 months. The 2 arms were: one was venetoclax dose ramp-up schedule, which we discussed, just reaching 400 mg per oral daily over 5 weeks, then continued 400 mg daily from cycle 1 to cycle 6, during which it was accompanied by rituximab standard method 375 milligram per meter square in the first cycle, and then 500 milligram per meter square next cycle onwards up to 6 cycles. And the other arm was bendamustine and rituximab, which we use normally. And then after that, the venetoclax arm continued to give monotherapy until the progressive disease or 2 years of treatment. And in the later on, that modification was made where the retreatment with venetoclax was allowed if someone progressed on venetoclax arm, and this was allowed for 2 years again, fixed combination, fixed duration. And the bendamustine arm was also allowed to cross over to venetoclax rituximab arms. The primary endpoint was investigator-assessed progression-free survival, and secondary endpoints were investigator-assessed PFS and minimal residual disease negativity. So the 5-year analysis, which is presented now, shows the median progression-free survival of 54 months, approximately 54 months in the venetoclax arm versus only 17 months in the bendamustine arm. Percentage-wise, 5-year progression-free survival was 38% versus not evaluable in the standard arm. The hazard ratio was very significant, 0.19, and the p-value was 0.0001, which was again very highly significant. Similarly, median overall survival there was a difference in median overall survival. It was not evaluable as per months, but 5-year overall survival, there was a 20% difference between both the arms, and a very impressive hazard ratio of 0.4, and highly significant p-value of 0.0001. Now, according to undetectable minimal residual disease status, so we find that if what is the definition of undetectable MRD? If we find one cell in 10,000 cells of one CLL cell in 10,000 cells, if it is less than that, it is undetectable MRD. If it is more than that, but less than 1 is to 100 cells, then it is low MRD. And if we find more than one cell in 100 cells, then it is high MRD. So at 24 months, the progression-free survival after the end of treatment, percentage-wise, was 86% in undetectable MRD, and low MRD it was 52, and in high MRD it was 8% only. So the MRD is a very important emerging biomarker in case of CLL treatment. It is prognostic as well as predictive. We will see it later. So at 36 months, again the same kind of progression was seen. 61-month PFS in undetectable MRD and 40% in low and not evaluable in high MRD. So if we compare with do the comparison between undetectable MRD and low MRD or high MRD, so between low and undetectable, the hazard ratio is 0.4, and between high and undetectable MRD, the hazard ratio is 0.02, which is very highly impressive. So we can see that undetectable MRD status at end of treatment is associated with improved post end of treatment progression-free survival as well as overall survival in the venetoclax arm. Here again, we see that among 83 patients, so we had 83 patients at the end of treatment who had undetectable MRD. 32 out of them continued to have undetectable MRD. 28 had MRD conversion from undetectable to detectable MRD without progressive disease over 19 months, and 19 patients had conversion to progressive disease over 25 months. Now, this is again a very good biomarker, MRD doubling time. So if MRD doubling time is high, if MRD doubling time is more, that is good. So the BR had MRD doubling time of 0.006, which is high. So high is bad. So if it is, that means the multiplication is occurring faster. So venetoclax had lower MRD. So venetoclax arm had doubling time of 72 days, whereas the bendamustine arm has doubling time of 52. Again, it was highly significant. So faster clonal growth rate is equal to shorter MRD doubling time. So now we go the correlation between the MRD and genetics. We cannot go away from genetics in CLL. So there are main three categories: deletion 17p, and then complex genomics and IGHV. We all know that mutated IGHV is better and best in all these categories. So we see that in deletion 17p positive patients, 100% patients progress to progressive disease, whereas only 22% patients progress to had progression if the deletion 17 was negative. Similarly, if a complex genomics was there, more than 3 variants, then 44% patient progress, whereas no GC, 20% patient progress. In unmutated IGHV, 37% patient progress to progressive disease, whereas in mutated, 4% only. So the median growth rate was, again, we can see that maximum growth up to the progressive disease or less doubling time was in deletion 17p positive patients, followed by GC positive patients, followed by IGHV unmutated patients. So what investigators concluded is that in patients with relapsed refractory CLL, 5-year progression-free survival for patients who received venetoclax, the undetectable MRD at end of treatment was associated with 62% progression-free survival at 36 months. So 62%, very impressive progression-free survival in the patients who had undetectable MRD. Median time to MRD conversion was 19 months, and median time to progression disease was 25 months. The undetectable MRD patients sustained undetectable MRD was 40%. The poor risk baseline characteristics associated with faster MRD doubling and in the venetoclax arm and sensitivity to retreatment predicted by initial responses and favorable. So favorable, the baseline characteristics as well as MRD both are important in deciding the progression. Then investigators concluded that these findings provide further support for the use of fixed duration venetoclax and rituximab in combination in patients with relapsed refractory CLL. Now, what is my take? The fixed duration therapies are need of the hour because it is difficult financially also, otherwise also because of the toxicity to keep giving the drugs indefinitely. The minimal residual disease is prognostic as well as predictive, because in this study it was seen that the patients who had undetectable MRD, and whenever they later on progress, they had better response to even same therapy, venetoclax arm also, venetoclax therapy also. Deeper responses lessen the resistance, lessen the toxicity because of lesser exposure, and improve the survival, overall survival, as well as progression-free survival. The genomics play key role throughout the disease course, at relapse also, otherwise from the beginning itself also. Now we have so many drugs in our armamentarium, so it calls for judicious use and judicious sequencing and minimizing the toxicity. Retreatment is possible, as we saw that the venetoclax arm again on progression was given retreatment, and 60% of them had very good response. And early use of novel targeted agents improves survival. So in many cases, especially in the where the high risk markers are positive, we can do away with chemotherapy and go with the targeted therapy. Here I end my presentation, so I am open for any questions. Thank you.
Thank you, Dr. Darling. That's a beautiful presentations. We have more options to treat CLL at diagnosis or at relapse or the refractory setting. There'll be many questions on this paper. Unfortunately, we wouldn't have time. Dr. Bhabe had a questions. It's a theoretical questions. Dr. Bhabe, I will answer that questions on behalf of Dr. Darling, because I think that kind of trial with this combination with obinutuzumab and bendamustine probably might not happen, and we may not have answer. Probably we will be continuing to treat these patients, whatever drugs available at our hand, provided cost allows it. Thank you so much. Thank you so much, Dr. Darling. Now I hand over the platform to Dr. Pankaj Malhotra, my friend, to conduct a panel discussion on DLBCL. Pankaj, please. Thank you.
Good morning. Thank you, sir. Thank you. And let me allow to share my screen, please.
So 1 minute, I'll just stop the participant sharing. So you can do it now, sir.
Okay, so thank you again to the organizers for giving me this opportunity. I think our panel discussion is until 10 o'clock, so we have just 20 minutes. But I think we have been discussing diffuse large B-cell lymphoma at various forums, and not much has happened in the last few years. Once we know that the cell of origin classification has come. After that, we have not progressed further, but we will discuss if we can reach some kind of a consensus. So, so the panel discussion is on diffuse large B-cell lymphoma. There is no specific type of diffuse large B-cell lymphoma or any specific situation. So my discussion would be general, on a general front only. So as I get the message, Dr. Priyanka and Dr. Uma are there, and of
so
course
Dr. Ravi is also there, sir. Dr. Ravi Kumar.
Dr. Ravi is also there. Okay, great. So we have 3 panelists, and obviously I was Dr. Tapan Sekia here for just giving his experience in difficult questions. Discussion points. The discussion point one is at the time of diagnosis, what is the minimum and maximum info they want to have before initiating treatment in a game. So maybe I can start with Dr. Priyanka first.
Priyanka ma'am, can you unmute your mic?
Yeah, good morning, sir. Thank you for the organizers for the opportunity to us. And minimum and maximum information on the biopsy we need to have is regarding the immunohistochemistry. to know what is the cell of origin, as we know that there are two types, the germ cell, the germinal center type, and the second one is the ABC type or the non-GCB type. So for that, we need to have what is the expression, what is the minimum amount of expression c-Myc, BCL2 and BCL6 are having apart from the IHC which are used to diagnose the DLBCL. So that is important, because if there is an expression, double expression on it, we need to further go for the fish to know whether it is a double hit or a triple hit lymphoma, as the treatment will be very much changing based upon the results we have for the double hit or the triple hit.
Thank you. Dr. Ravi or Dr. Uma, do you have any?
Yes, sir. I agree with Dr. Priyanka. I want to divide whether disease is germinal center type or activated B cell type. And in addition, we need mixed status so that we know whether it is a double expressor or double hit lymphoma. Yes, sir.
Right. Dr. Uma?
Yeah, I agree that there too. So obviously IHC is the current way in which we sort out the GCPs and the non-GCPs. Like you mentioned here, I would also look at the Ki67 to some extent, because, you know, more than 90-95% Ki67, I would think that they are more aggressive, and maybe my treatment would be a little more aggressive in these patients. Other thing is that for the fish, for MYC and BCL to BCL6, I'm not sure if we should do it in all or only in the GCB, because the double hit lymphoma is more commonly seen in the GCB, whereas the ABCs are usually known to have double expression of MYC and BCL2. So that would be a question to panelists, whether you do the fish on both, if it is a GCB as well as a non-GCB.
Right. Dr. Priyanka, do you want to respond to that?
Yes, sir. So I would say that, sir, definitely GCB are the ones who have the double hits and the double triple hits. But the expression, what is the percentage of expression is a matter of concern. And we definitely, even if it is an ABC and the expression of the MYC or the BCL2 and the BCL6 is more than 40%, more than 30%, as the cutoff says, we definitely, if it is more, we ask for a fish panel for the to know whether it is a double hit. Many a times it does not fall into that, but when there is an expression which is more, we go for the fish, the confirmation by the fish.
Right. So, Dr. your question, still have some question on the same. Okay. Yeah.
No, go ahead.
Okay. So, and few things are clear about the GCB, ABC, MYC, BCL2, BCL6, but some of the factors we are not sure about. For example, Ki and CD20. Some people say, you know, I would like to have this information on the biopsy just to know the behavior of the diffuse large B-cell lymphoma. If the Ki index is more than 60, 70, or reaching up to 90%, that means these lymphomas are going into the quality of Burkitt kind of a lymphoma. Although the management may not change, but it is sometimes good to know the kind of a lymphoma you are dealing with. So about CD20, CD30, again, some information that people say that if this information is available and it appears that the diffuse large B-cell lymphoma is an aggressive form, so some people might consider giving brentuximab upfront, although this is still, you know, experimental. Right. So this is about the pathological and clinical characteristics of large B-cell lymphoma according to the WHO. So just, you know, the same what the panelists have already said. Molecular subtype GCB about 60%, ABC about 25 to 30%, unclassifiable about 10 to 15%, and new molecular entities are recently characterized. And this is the IHC on this. the median age, and the nodal presentation in most of these patients. All right, the discussion point number 2 is the CNS risk stratification. I think because this is the most important thing when you diagnose the patient as diffuse large B-cell lymphoma, and always in the back of your mind, you are worried about this patient should not have a disease in the CNS. And in spite of the fact that we do not have a clear characteristics or information on that, but in the back of our mind, we have this point. So I will ask my panelists, how do they risk stratify their patient of diffuse large B-cell lymphoma in terms of CNS infiltration? So Dr. Priyanka first.
Thank you, sir. So CNS risk stratification is definitely important, and the more and more we are doing these seminars or the academics, we do understand that CNS risk stratification is a part of our diagnosis, like the way we do it for even the IPI scoring for the DLBCL. So based upon the age, the performance status, the LDH, extranodal sites, stage, whether there is kidney or adrenal involvement, we do the risk stratification. And extranodal sites are very important. As I already mentioned, kidney and adrenals are no doubt important, but if there is a bulky disease, midline disease, testicular involvement, thyroid, breast in females, so these apart from, even if the patient does not have a CNS involvement or there are no features of CNS involvement, at the basic workup, we also do a CSF study, though we know it is more of a parenchymal involvement than a leptomeningeal involvement. But we do a CSF study in patients who present with bulky nodal masses. And based upon the CNS stratification, we understand that if it is CNS2 or CNS3, they are at high risk of having a CNS relapse even at the end of, by the end of treatment, that is at 6 months. And previously we used to do as IT methotrexate, but now the protocol, as per the protocol for RCHOP, patients on RCHOP 3 weekly regimen, we do it at around day 10 to 11 as per the guidelines with a 3 gram per meter square with the rapid rescue of methotrexate. And we have not found it really difficult to manage cytopenias. Patients do not land up in much of cytopenias. But when there are double hit lymphomas in patients who undergo dose adjusted epoch R therapy, it's difficult for us. And in those cases, we do IT methotrexate. And possibly we have not yet practiced, but in many forums we discuss that at the end of therapy, we may go with a high dose methotrexate for the parenchymal prophylaxis. And just to add upon, recently there was even a paper where they have again had a head-to-head trial regarding IT prophylaxis compared with high dose methotrexate, and they have found that there was no superiority or it was non-inferior. So either of them are true. So in the coming years, we possibly will be able, because the results will be a little bit robust by then, the data will be robust, and we can have a definitive way whether it is the IT methotrexate or it is the CNS directed, the high dose methotrexate, which is a better one.
So thank you, Dr. Priyanka. I think you have covered almost all the aspects of CNS risk stratification as well as treatment. So Dr. Uma, do you have anything to add?
Not really. I think she's completely covered the topic in entirety. So.
Sorry, very sorry.
No. It's excellent.
No, it's very good actually. I mean, you saved us the trouble.
No. I think she has given a very, very, very extensive review of the CNS. Dr. Ravi.
Very crisp.
Yeah, very crisp. Very crisp.
Very nice.
Thank you, sir.
Yes, sir.
So my question. Sorry. So have everybody stopped giving intrathecal methotrexate is my question.
Not truly. Not truly.
Not truly. Because many times, when we do the CSF, we also inject the intrathecal. And
yes.
Especially in patients who have kidney compromise, how do you do with the high dose methotrexate?
Madam,
because in that case, in those patients, I would prefer to give intrathecal methotrexate. That would be my comment.
Yes, madam. Suppose it is a CNS, suppose it is a TLS-induced renal failure. Most of the time, first cycle we give the IT methotrexate, and following that, if the renal parameters stabilize, we go with the high-dose methotrexate. But having said that, whenever there is a patient with CKD, definitely I would not prefer to go for with a high-dose methotrexate. Rather would go with a triple IT or a IT prophylaxis.
Right. Dr. Ravi, you were saying something?
Yes, sir. Even for old patient, I would prefer intrathecal methotrexate, and I would also check HIV status, and albumin status, because many guidelines mentions low albumin status is also risk factor for CNS disease.
Right.
Yes.
So coming back to the question in patients with the renal failure and in patients whom we feel that the risk is high, but we cannot give high dose methotrexate or so. So all these strategies are okay. So even though we do give high dose methotrexate in some patients where we consider as the CNS risk is high, but nobody has shown that this is really useful and this really help the patients in prevention of CNS disease or so. So obviously you look at the risk and benefit ratio in a given situation and then take the decision. Right. So we go to the discussion, the last discussion point 3. Situations where you do not use R-CHOP. We know R-CHOP is still the standard of therapy for diffuse large B-cell lymphoma. But then there are situations where we do not use R-CHOP. And I would start from Dr. Ravi this time. I let me
Yes.
give other.
Very sorry, sir.
No. Dr. Priyanka, no. I just thought, maybe
No,
in a
sir,
reverse
it's
order.
all
So
right. Yes,
maybe
yes.
Dr. Ravi, you can start.
Yes, sir. Those patients who are not fit for doxorubicin-based therapies, in many studies they tried etoposide and gemcitabine. They replaced
Right.
doxorubicin in the form of RCEOP protocol or RGCEP protocol. Even for aggressive lymphomas, we can try dose adjusted repose regimen with doxorubicin, and it can be safe in cardiac compromised patients. Other options are sir, those patients who are not fit for aggressive therapies, rituximab bendamustine is also the option.
Right. So Dr. Uma?
Yes.
Situations where you do not use R-CHOP upfront.
Yeah, so patients who have a cardiac compromise or, like you mentioned here, with poor EF where they're not fit for anthracycline based therapy, there we would probably replace it. I'm more comfortable using etoposide, so that's what I do. Elderly age group, mini R-CHOP is what we can use, which I have used. Targeted drugs which you've mentioned, Brutinib, lenalidomide, I have not really used it. I'm not sure if there is any data has not really shown any benefit right now. Maybe future will be different. In more aggressive lymphomas, like I said, when the Ki67 is high, or whether if it's a double hit lymphoma, there I tend to go for a dose adjusted REPOC regimen.
Right. Yes, now we go to Dr. Priyanka.
Yes, sir. For regarding ibrutinib and lenalidomide, I have used in some of our patients who have relapsed. So in those cases, RIL patient who have relapsed on R-CHOP, RGTP with 1 or 2 cycles, they have had a stable disease or a progressive disease. Ibrutinib, lenalidomide, rituximab is also an option, but I do not know regarding long term how well they fare.
Yes, so specifically, GCP or ABC, where do you use this?
It is mostly the ABC type where lenalidomide had previously shown some advantage in the ABC subtype, and there is some amount of CNS penetration also with the lenalidomide. So in patients who are elderly, but I would say mini R-CHOP is a very good regimen even for the elderly. Previously, we used to give apart from this the RCVP. But based upon, like, if you compare RCVP and mini R-CHOP, it is quite tolerable regimen with a very good outcome. And suppose it is very frail, definitely patients, elderly frail patients, ibrutinib, lenalidomide, and rituximab may be also an option.
Right. So again, coming back to the patients who have cardiac dysfunction and coronary disease and cardiac dysfunction. So we keep on actually debating. One is to replace adriamycin with etoposide or gemcitabine, but many people say that try epirubicin, mitoxantrone. What is your view on changing from mediamycin to mitoxantron or to epidubicin kind of a thing? Any experience, or what are your thoughts, Dr. Priyanka?
Sir, I have not used mitoxantron. We have used etoposide. Etoposide is quite a safe drug, RCEOP. We use that as RCEOP. It is quite a safe drug and quite tolerable. But if the patient would not have a cardiac compromise, R-minichop would still be my therapy of choice.
Right. So, Dr. Tapan Sekia, if you are there, sir, what is your experience of using mitoxantron?
You know, in 40 years of life, you have used everything. Seen everything. Dr. Priyanka has summarized very well. R-CHOP is our comfort zone, right? So if we go out of R-CHOP, I always give the patient 10 minutes extra time every time we meet, because we don't know how things might go wrong. That's my approach, so that they are comfortable, whatever treatment we advise. That's what I would say.
Yes, I think that's a very good pearl from Dr. Tapan Sekia, the experience-based pearl, that when you are deviating from R-CHOP, then you need to spend 10 minutes extra or maybe 15 minutes extra with the patients. And so all these, are the routine questions which you face in your clinic. So in PGI, we designed a new protocol which is called L-probe. And this L-probe is actually consisting of L is lenalidomide, P is prednisolone, R is rituximab, vincristine, and bendamustine. So we had only a few patients, 10 patients, and at that time the guidelines for the clinical trial were changing. So, but in these 10, we have a good response with this form of combination, and we published a short report in the I agree with Dr. Priyanka that now in these current days, the trend is towards using mini R-CHOP in the elderly patients. So, and for plasma
there is a
blastic,
question from Dr. Abhay.
Yeah.
The question, just if I can bring it up, Dr. Abhay is asking a questions. ABC, DLBCL, 67-year extensive disease, R-CHOP or R dose adjusted epoch?
The patient can tolerate if ABC type, many people would prefer giving DAR epoch. It all depends. I don't want the first safety of the patient, and then is the curability of the patient. So I would first see that whether the patient can tolerate dose adjusted DAR epoch. If yes, then go ahead. If no, then R-CHOP. So since we are, I think we have to finish by 10 o'clock. So we have just 2 minutes. So I would just show here that for plasmablastic lymphoma, this was one where we actually added lenalidomide with and you can see at the time of presentation, this is a large mass on the side. This was a response after 2 cycles, and this was response at the end of the therapy. So sometimes you do all this kind of modification in your clinic, and just a couple of days on the NGM public review article on diffuse large B-cell lymphoma, where all these queries, questions, what you have in your mind have been updated. But again, I would say that you are almost where you started 4 years ago, you are almost at the same point only. There is not much of change in therapy, what we have discussed in this panel discussion. With that, I thank you very much for all the panelists. And if there are questions, then we will be happy to.
Thank you, sir.
Thank you all. Thank you. Thank you, organizers.
So I hand over to organizers if there are any questions.
So there is a question from Dr. Abhay. I'm not sure if you've taken that question. Does the extent of the disease make you choose one over the other regimen?
Not exactly. I answered that. Not exactly. So it depends on the GCB and ABC type and the tolerability of the patient. So based on that, you decide about the treatment decision.
I am
Perfect,
still
sir.
an R-CHOP man. I am still an R-CHOP man. Though, as I said, R-epoch has not convinced me yet. But the patient wants it, I go ahead. But the data is very inadequate at this point in time to really convince people. I said, convince me. We have used all kinds of cytobomb, pickup, you guys think that except for the nuclear bomb, all kinds of treatment we have used in DLBCL. I think we need some molecular studies and then more targeted therapy beyond R-CHOP.
Very well said, sir, because you have seen all those things. So currently, we try to follow the fashion or the trend which is going on. So if the trend is for DAR epoch, you tend to follow that these days. So it all depends the current trend which is going on, like fashion. Thank you so much.
Thank you so much, Pankaj sir. Thank you, Tapan sir, and thank you to all the panelists and the speakers. We'll now move on to our next session. Our chairperson for the next session, which is on multiple myeloma, is Dr. K. Pavitran, who's a senior medical oncologist from Kochi. So without wasting any further time, I would like to hand over the mic to Dr. Pavitran.
So we'll go for the next session, that is on multiple myeloma. And the speaker is none other than Dr. Swami Padmanabhan. He is a professor of lymphoma and myeloma at MD Anderson Cancer Center, Texas. Dr. Swami Padmanabhan, please.
Yeah, thank you, Dr. Pavitran. If I can share my screen. Okay, here we go. So thank you. It was a very lively discussion with Dr. Pankaj Malhotra and Dr. Tapan Saikia and others. It's good to see the debates. And Dr. Manoj Mahajan, thank you for the invitation to speak on this session. The initial idea, so I don't do myelomas anymore, even though I'm the Department of Lymphoma and Myeloma. We tend to specialize, and I'm going to speak about general principles of CAR-T in lymphoma and myeloma. And you'll probably see some data in myeloma. Obviously, there's no approval as yet. And it's come a long ways, as you will see. A lot of this is because of the
Sir, sorry to interrupt you, sir. So can you make the slides full screen, sir?
Presentation? Yes,
yeah, so please,
I should do that.
Thank you so much.
Thank you. Okay. Just give me 1 second. I think it has to. Can you see this? Or is it still in the presentation mode?
Sir, it's still in the presentation mode, sir.
Okay. Now you should be able to see it.
Noted.
Yes, sir. Now you can see it. Now you can see it.
Okay, very good. It looks like there's a lag. Thank you once again. And some of the studies I'll show you are because of the participation of the patients without whom we wouldn't understand the biology better, and we can move away from some of the chemotherapies that we've used in the relapsed refractory setting. And essentially, a lot of the studies that we do in myeloma and lymphoma with the CAR-T are in the relapsed refractory setting. And unfortunately, as you know, there are many patients who do relapse, even though the frontline therapies do give a good control. So the three-pronged therapy that I'm going to speak today consists of three principles. One is that the hematologic malignancy is a genetic disease, and you have sophisticated therapies, whether it's immunotherapy or targeted therapies or cellular therapy, which has made a huge difference, and each person is unique. And in that context, T-cell signaling has taken off in the last 20 years or so, and that's where the chimeric antigen receptor T-cell therapy has made a huge impact. As you all heard yesterday, the CAR-T therapy is approved for follicular lymphoma. It's the sixth indication that we see in hematological malignancies. So I'll try and cover some clinical studies in lymphoma and in myeloma, at least the pivotal study, and talk about some of the common side effects, AE management that one would expect to see, including cytokine storm and neurological complication, and then maybe talk a little about going beyond auto versus allo CARs. And so we'll talk about the first 3 points. And one of the things that we have learned through the hallmarks of cancer, and this is work that's been put together by Robert Weinberg and Hanahan at the Mass General for over many years, is trying to understand this biology of cancer itself. And one of the things that the cancer does is evades immune destruction, as we all know, through the HIV story and immunocompromised patients with transplant, that immunosuppression leads to diseases, including lymphomas. And now we know that the immune system actually exerts control. So how can we exploit that to treat diseases? We've used chemotherapy, as you heard in the previous sessions, or targeted therapies to treat either lymphoma or myeloma. So it's based on this two single hypothesis, which is that the immune system, unlike chemotherapy, requires two signals to activate and kill the target. The signal one is antigen presentation. So if it's an antigen that is presented of an external protein or a new protein, in the case of a tumor-associated antigen, that's your signal one, saying that something is wrong in that particular cell. It could also be a cell that's infected. Signal two is co-stimulation. Co-stimulation are these molecules that strengthen the signals. CD28 is one of the co-stimulatory molecules, and it finds the ligand, which is CD80 or CD86. CD137 or 41BB is another co-stimulatory molecule. So there are many such, like OX40, etc., which are also signal 2. And you also need signal 3, amplification of this whole process through cytokine signaling. And so a lot of cytokines that come together, such as interferon gamma, IL-2, make this T cell attack possible and very specific, because the first property is the antigen presentation, so the T cell is able to pinpointedly attack its target. With that being said, and this is just one of those examples of the immunological synapse that you see between the CD8 cell and the target cell, in this case the tumor cell, and then the CD8 cell actually makes holes after this engagement through type 1 and type 2 signaling and kills the cell through fast ligands or through granzymes or through perforins. It's a very fascinating process, right? So how do we exploit this? And this has taken at least 30 years. The first development of trying to take a TCR and putting it in a cell was done by Zelik Eshar in Israel in 1989. And fast forward in 95, Steve Rosenberg and several others at the National Cancer Institute started using these therapies in melanoma. And then the rest is history since 2000 onwards, with several people, Helen Heslop, Malcolm Brenner, Carl June, and several others started using the single chain antibody molecule to put it as a cassette in autologous cells and give it back to mice and then to patients. And then the first studies were done at NCI. Kokondoffer did studies in myeloma and in lymphoma, using different targets. And that's how the whole idea of CAR T therapy exploded. Today, we have 6 indications for CAR Ts in lymphoma, myeloma, lymphoma and ALL, and very likely in myeloma very soon. You can see that it's increasing. And these are all autologous cells. And there are 3 different products that have been approved. One is Escarta, the other one is Kymriah, and the other one is Lisocell. And you will very soon see the BCMA approval in multiple myeloma also. So the advantages of the CAR T is the following. It's HLA independent antigen recognition, so it doesn't really need that signal 1. Therefore, there's a universal application, but you do need one target antigen, or at least one target antigen, or more if you want. And the most popular ones are CD19 and BCMA, which we'll talk about. And there's very rapid generation of tumor-specific T cells, whether it's autologous or allo. Allo is much faster, and it takes days to weeks, and our turnaround time for lymphoma is about 17 days. And it's active in both CD4 and CD8 cells. There are a lot of nuances in this. There is a risk of autoimmunity or GVHD, but with autologous cells, it's much less. So in other words, it's a living drug. It's a single infusion. There's nothing else in the history of mankind, I should say, that there's a single living drug that actually gets rid of the tumor to a large extent. And is it curative? Very likely. I think you have the longest data sets that show that that's a likely possibility. And so in its construct, if you look at the design of the chimeric antigen receptor, the antigen of interest is the tumor antigen. And so you have the monoclonal antibody sequence that is taken that recognizes the tumor specific antigen or tumor associated antigen. In this case, CD19 or BCMA, you can substitute the antigens. And this becomes the signal 1. And the signal 1 is a transmembrane protein. And in its first iteration, this is attached to the zeta chain of the CD3. So the combination of CD19 and the CD3 makes it the chimeric antigen receptor. The first generation just had these two pieces in it. And as you can see, the advantage of this is it has a specificity of the antibody recognizing the target, which is in this case CD19. And plus, it also has this effector mechanism through the CD3 zeta, which allows the killing to happen with the signal 1 and signal 2. So the first generation, as I pointed out, only has these two elements. The second generation has the co-stimulatory molecules, which you talked about, which gives it the second signal. The most popular ones are the CD28 and the 41BB. The third generation may have two co-stimulatory domains, or it might have 2 or 3 different antigens in its construct. So we are at the second generation for the most part that we will talk about with all the CAR-T approvals so far. And third generations are also on the way. So to construct a CAR-T, it is a process. It is sort of like a stem cell approach for an autologous CAR-T construct, wherein you have this CAR gene with the antigen and the CD3 zeta and its co-stimulatory molecule that is subcloned into a vector. It is transduced into the patient's immune cells, I should say, and specifically T cells. And this is getting better with time. And with the help of certain soup, if you will, cytokine soup such as IL-2 and anti-CD3 and CD28, these are expanded and they become engineered. And you use several cassettes, and the way it gets into the cell is based on various vectors. Lentiviral vector is one of them. Retroviral vectors are other examples. Sleeping beauty transposons are other examples. And once these genetically modified cells are produced, it gets infused into the patient. And so if you look at the lymphoma, what are the markers that are likely targets? CD19 is very popular because it goes all the way from a pro-B cell all the way up to a mature B cell and stops short of a plasma cell. Obviously, you have other candidates such as CD22. CD79 is also a good target. It spans along all the maturation of the B cells. So if you look at the cartoon here, in this case, it's an ALL or a CLL. B cell tumors on the left-hand side, the CAR T cells are on the right-hand side. So it goes and attaches to the target of interest. It kills through the perforin mechanism. And you can see that that's how the cells get, the tumor cells are gone. And this, by the way, is the picture of Emily Whitehead now. It's the girl that lived after 2 allotransplants for ALL, and it's 10 years later that we think that people like Emily are cured of this terrible hematological cancers and possibly even solid tumors. So that being said, there are multiple viral vectors. We won't spend time on it, but there are lentiviral, retrovirus vectors, and there are different methodologies, so a lot of technical details to it. How about myeloma? In myeloma, there are several antigens that are expressed. BCMA is one of the most expansive ones, which is present in almost normal plasma cells and maybe even a few subset of mature B cells. And this is the monoclonal antibody that is used that identifies the BCMA. The other target is CS1, which is usually seen in NK cells, but also expressed in plasma cells. And as you know, that the CS1 antibody is elotuzumab, and the elotuzumab antibody is also used for CAR-T. And there are ongoing studies with that. There are other targets, but the only thing that's worth mentioning right now is BCMA, and there are several big companies which are doing BCMA. BMS is probably the one that's forefront ready for approval. So we'll see what the pivotal data looks like, but there are several other candidates as well. So there are challenges at autologous transplant, and I won't spend much time on this because of the fact that it takes time to collect the immune cells from the patient. and do this ex vivo procedure of T cell expansion before it's infused to the patient. So there's a downtime of 4 to 6 weeks, and which is a problem with autologous CAR T cells. And these days we have, in the last couple of years, we have allo CAR Ts that have a transformative potential. And essentially you have a donor which that allows the leukapheresis to happen. You have this whole production that happens in the donor cells. And obviously there is this concern for the allo GVHD effect, and I'll come to that in a second. But the idea is very simple. If you have a good donor with no chemotherapy, a healthy patient, the T cells are going to be very fit, and you have a good chance that they would be good way to make CAR T. So how are the CAR Ts done? Some of the methodologies are TALEN and CRISPR. And CRISPR, as you know, led to the Nobel Prize approval process last year with Jennifer Doudna and Emmanuel Charpentier. Essentially, it's like cut and paste technology of the genes. You cut a gene, you use a guide RNA, use this CRISPR technology, cut a piece of gene with Cas9, and then introduce the gene of interest. And with this technology, we are able to develop several allogeneic CAR Ts, and there are several, including BCMA for multiple myeloma, that are on clinical studies, CD19 for lymphomas, CD70 for lymphomas, and other solid tumors as well. So it's highly effective, and we won't spend much time on that. One of the ways that CRISPR is able to get rid of the GVHD effect is by knocking out this TCR. As you can see here, the TCR locus, which is the one that determines the expression of foreign antigens in the donor cell, when it's completely eliminated, your chance of GVHD is completely gone. So this is so efficient that 100% of the TCR is gone. And beta-2 microglobulin elimination also allows with expansion of the allocars. In other words, you have the capability of taking a donor and making tons and tons of donor allocar Ts, which is the case, and that's the wave of the future. But let's stick to what we have right now. When I explain CAR Ts to patients, and this is a good analogy, it is sort of like looking at someone like Robert Downey Jr. on the left-hand side, and then when he undergoes transformation, he becomes Iron Man. So for an allo CAR T, it's like somebody who comes from outside, like Clark Kent is an allo person, is not a human. And of course, he becomes Superman. So that's sort of the analogy that I use that makes it easier for some of the patients to understand, what is this CAR T? It's just your super immune cells, whether it's yours or made from somebody else and can be given to you. So that being said, this is the preclinical work. It's very fascinating. There's a lot of things to come. What do we have for clinical studies? So I'm just going to cover briefly the diffuse large B-cell lymphoma and also in the myeloma, and go to some of the side effects. Just to show you this landscape, you can see that not the US, China is actually leading in terms of CAR T therapies. This is an older map, but it sort of stays true. Some of the other studies are in Europe, and you can see the other gray areas in between, including India. So I think there needs to be more CAR T studies in India as well. And I won't get to some of the other studies that we're doing, but we'll talk about the first CAR Ts that were approved. This is in diffuse large B-cell lymphoma. And you heard the story of diffuse large B-cell lymphoma in the panel discussion. The initial standard therapy, whether it's ART, CHOP, or anything else that you give, there is a failure rate. And the failure rate can be as high as 60%. And the second line standard therapy sometimes can be largely ineffective, and it's a 10% cure rate. And now you have this biology of ABC, or the non-germinal center type, and the GCBs. And so this is the snapshot of the 3 CAR T products with the survival information. The overall survival in Zuma-1, which is the Yescarta, is now 5 years. Juliet is close to 5 years, and Transcend, which is just recently approved, which is the Liso-cel. So Zuma-1, just for illustration purpose, I'll show that Zuma-1 is the first study that allowed the approval for Yescarta in diffuse large B-cell lymphoma in patients who failed 2 lines of therapy. This is a CD19 CAR T with a CD28 as a co-stimulatory molecule. And just to get to the framework of CAR Ts, and no matter what the CAR T is, there is a general schema that follows through. Essentially, if it's an auto CAR T, it's a leukapheresis, and then there's downtime for 3 weeks or so, and then the cell product arrives, and the patient starts the conditioning chemotherapy, and that's day -5, and it's fludarabine and cytoxin given for 3 days, and then you have 2 days of downtime, and then your day 0 is the day of the CAR T infusion. And then you have the days that start just like transplant +1 all the way up to day 30, and you can see that the first 2 weeks are the most important because some of the effects of the CAR Ts as they expand happen in the first 7 to 10 days. And also the target killing also happens the first 14 days and this interaction of the T cell with the tumor. But before the T cell can interact with the tumor, there's a lot of noise. There's a lot of cytokines that are secreted, which gives rise to this term called CRS that need to be monitored very carefully. After 14 days, generally these things come down, and then you have day 30, which is your first assessment of the tumor that happens. And this is the expansion with Yescarta, the ZUMA-1. You can see that the expansion is very dramatic. If you give a CAR T, let's say it's about 100 million cells, each one of the cells proliferate to 10,000 times. So in other words, you have this suddenly an army, a super army, I should say, of cells that are target seeking and go after either a 19 or a BCMA. And it's typically the case with no matter what the CAR T is. And some of these CAR Ts do persist for some time. And this autologous CAR Ts particularly persist longer than an allo CAR T. And in ZUMA-1, obviously, these are patients who failed 2 prior lines of therapies, very sick patients. Comparative, the Scholar-1 study that was done showed that the response rate, if you give chemotherapy of your choice, is about 10%. So these are the group of patients that were chosen. And obviously, the response seen initially were about 52%. Dr. Satwanilapu updated this data set in 4 years, showing that 50% of them maintain the response beyond 4 years, and there's a flatlining of the curve. And no matter what the subtype risk groups are, there is a benefit across the board. And this is the forest plot analysis. And there were some side effects, which I'll specifically speak to, but CRS, which is the cytokine release syndrome, and the neurological toxicity, which is now called ICANS, ICANS, it happens. It's a little higher for Yescarta compared to Kymriah and Kymriah compared to Liso-cel, but nevertheless, you do see these 2 events that might happen in the first 14 days. It can happen all the way up to 3 months, but for the most common, it's restricted to the first 14 days. This is an example of a patient who was treated with diffuse large B-cell lymphoma, multiple prior therapies, and you can see that at 3 months, it's all gone. And it's a dramatic response that you see in many patients. This is another patient. This is actually a patient from India with skin lesions before treatment and 1 month after treatment. And you can see the progression-free survival. You can start seeing a flat curve. And this is very much the case for all other CAR Ts as well, including the follicular lymphoma approval that happened yesterday. So the persistence of the CAR T is perhaps one of the most important reasons that allows this complete responses to happen, because initially you have a PR that might even translate into CR because the CAR Ts continue to work beyond the first 2 weeks, and the durable responses are seen in patients. And sometimes you don't see persistence of CAR Ts, but the peak that happens also has been shown to be important. So Scholar-1, chemotherapy, you can see on the left-hand side, or ZUMA-1, you can see where the curves have dramatically been lifted in terms of survival. And this is just a comparison of ZUMA, Juliet, and Transcend. There are differences in the CAR T design. The Transcend, I should say, that it has a selection of CD4 and CD8s in the right proportions. The conditioning regimen were the same. The tumor types were slightly different, and you can see the response rates are more or less the same. From what we feel in MD Anderson, there is a bias that the Yescarta perhaps has a better durability. It also has the longest data sets among them all. And this is the best response with all the 3 products. You can see that it's anywhere between 80% for the first 6 months, and then it starts moving between 45 and 55% for 2 years and 3 years and beyond. So what about the side effects? The CRS is the cytokine release syndrome, and it is graded, and there are different grading systems. The ASTCT, or the American Society of Transplant and Cellular Therapy, has come up with this grading system. now has changed the way we grade these things. And it's common for all CAR T products, no matter if it's for myeloma, lymphoma, or leukemia. And you can see that the grade 3s are important. They're significant. Why? Because they need treatment. And there's a reason why it happens, and I'll show that in the next few slides. So I'm also going to talk about myeloma because that is my original presentation topic. BCMA, we talk about that being a target that is universal. And BCMA actually is a B cell maturation antigen. It belongs to the TNFR superfamily. It's very close to the BAF receptor. And it has other ligands such as APRIL, and which is a proliferation inducing ligand. And it constitutively, the APRIL BCMA signaling cascade leads to increased number of myeloma cells. Obviously, the BCMA, knocking out the BCMA as a target is very, very useful. And there are several clinical studies for CAR Ts now in multiple myeloma. There are at least 25 clinical studies, but these are the earliest of those ones that were done. And the series 19, the lentiviral vector 41BB, was one of the first ones that was done at University of Pennsylvania. So if you look at the first study for BCMA, this is the 401 phase 1 study design, which is a phase 1 study. By the way, phase 1s in CAR Ts doesn't make sense as you don't have a phase 1 typically for a transplant. But since there is a dose escalation of the product, they're all considered as a phase 1. And in the phase 1, there's an autologous BCMA product, which consisted of this downtime of 3 to 4 weeks. There's leukapheresis in the manufacturing that happens, and then the infusion after the flu-cy, lymphodepletion chemotherapy, and then you have this bone marrows that are done at week 2 and bone marrow done at week 4, and the assessment that happens at the time. Of course, there is a dose escalation in this phase 1 from 50 to 150 to 450 million, and all the way up to 800 million. So the responses were somewhere between 150 and 450 million. Excuse me. So the dose expansion, they also looked at the BCMA expression of 50% or greater than 50%. And these are the baseline demographics and clinical characteristics of patients. You can see that the median follow-up, and you can see the ECOG status of these patients. Obviously, they were a highly select group of patients with good performance status, and about 38 to 40% are at high risk cytogenetics. And if you look at the treatment histories, 100% of them had received proteasome inhibitor and IMiDs. So these were refractory patients, and it's about 3/4 of them also had received daratumumab. So this is a triple refractory, if you will, from IMiDs and with proteasome inhibitor and daratumumab. Obviously, there are not many options that are durable, and so this is a good therapeutic option for patients. And I think my slides got misplaced, but I can tell you that the response rates that were seen in these patients were close to 90%. And the progression-free survival was about 11 months. In other words, you have a response that lasts for 90%, but then you start losing the response after a point, and they're still investigating why that happens. It's because of downregulation of BCMA, or because of other reasons. Maybe perhaps the CAR Ts were not enough, and combination strategies are being planned. So coming back to some of the side effects that you expect to see in the first 2 weeks, and spend a little bit more time on the cytokine release syndrome. So as I said, the CAR Ts expand, and they expand, they kick up a lot of storm and secrete a lot of chemokines and cytokines. And so the systemic inflammatory response caused by the cytokines, because this expansion is what causes this, and it can affect any organ of the body. So any of these things, whether it is the bone marrow causing cytopenias, kidneys causing AKI, more likely constitutional symptoms are the most common, which includes fever, rigors, malaise, which typically happens and can be easily identified. So if you look at the cytokine storm itself, there is this wave of cytokines that comes at different time points. If you go back to the same schema of conditioning and then the CAR T-cell infusion, the first wave is immune homeostatic cytokines, the chemokines, which consist of IL-2, IL-7, and IL-15. So it's the early phase for the first 4 to 5 days. Then you have the mid phase, which is inflammatory cytokines, more IL-6. You have some IL-6 coming up, but then more IL-6, IL-8, and then IL-10. Then you start seeing interferon gamma appearing, and then that's the middle phase. And as the interferon gamma increases, then you see the release of granzymes and perforins, which is what gives the cell kill. And it's been pretty much plotted that these are the cytokines that happen no matter what the target is. And these are detailed graphs of the various cytokines peaking at various time points. But we do know that the mid phase is probably the phase that produce cytokines and chemokines that are more harmful than helpful, because the interferon gamma and the perforins and the granzymes are the ones that knock off the cells. But the mid phase cytokines, particularly IL-6, is the one that causes a lot of the symptoms. In fact, at the level of IL-6, as you can see, it correlates with the cytokine release syndrome. And luckily, we have the anti-IL-6 antibody, which we all today in the COVID world know about this very well. Tocilizumab and ciltuximab are used for the management of severe CRS. Another cytokine that also goes along with this is IL-1 beta. So IL-1 beta antibody anakinra is also approved, is also used to manage certain CRS that is not managed by tocilizumab alone. One of the easiest ways to look for cytokine release syndrome is fever. And this is fever that happened in a patient with diffuse large B-cell lymphoma, got axi-cell, and typically happens in the first couple of days. And then you can see that you don't always give tocilizumab right away. You manage them with Tylenol and ibuprofen. In myeloma, you try to avoid ibuprofen, and you manage them with the cold packs. And if the fever doesn't come down in 48 hours, or if there are other signs of a grade 2 CRS, then you use tocilizumab, and you can use up to 2 doses or more if necessary. And ciltuximab is reserved for those patients who don't respond to tocilizumab. The other marker that also correlates with this is C-reactive protein. C-reactive protein also goes up, and it's a sum total of all the IL-6 responses that happens. So in ZUMA-1, for example, you can see that the peak CAR T cell expansion was very much important for the responses, and also to a certain extent for the CRS. And so to some extent, the conditioning regimen also is responsible for some of the side effects that you see. And we are still tweaking and trying to find out what the right lymphodepletion treatment is. We actually have gone from using single agent fludarabine to adding Cytoxan to higher doses, and now back to the standard dose that we use over 3 days. And the drug that is often used to treat CRS, if it is not treated by tocilizumab, is steroids. We generally try to avoid steroids, but in this particular study, ZUMA-1, using steroids was not found to be deleterious to the effect of CAR T cell expansion. As you can see in these graphs, there have been studies showing that if we use steroids earlier, it might actually reduce the chance of another side effect, the ICANS, which is the chemokines and the chemicals which irritate the brain and cause all these neurological changes. And the assessment is done with the ACT-CT grading system. And this is CRS grading on the left-hand side. And you can see that the CRS in management includes vigilance. So the patients have to be in the hospital, a good team, a good infrastructure, infectious disease, pulmonary doctors, cardiologists, and tocilizumab available to be given anytime. The ICANS is another neurological toxicity, which involves, it could be a lot of things. It could be aphasia. It could be just changes in mentation. And this is an example of one of the mini-mental score points that you do, which is handwriting. And you can see on day 4, this is the patient. On day 5, and after the TOSI is given, the TOSI doesn't change a whole lot. And the only thing that treats the ICANS, especially the grades, and they're graded from grade 1 to grade 4, is steroids. Any ICANS greater than grade 2, steroids are the best treatment. Sometimes we even move them to the ICU, because after a point when they become aphasic and are unable to speak, you have to protect the airway and intubate them prophylactically and take them through the process. And with steroids for a couple of days, they recover, and then you're able to extubate them. But then it's a much more harder process in the patient, and they have to go through physical therapy and get back on and it's very reversible process. We have done this over and over again through ICU and back, and many of these patients just go back to normal as though nothing happened in the previous 3 to 4 weeks. Another side effect that happens is hemophagocytosis. And we don't know what to call this as HLH because there is no splenomegaly according to the HLH criteria. This is more like the MAS, or the macrophage activation syndrome. Anakinra is the best treatment for this hemophagocytosis. Whenever one of the first symptoms of or signs, I should say, of hemophagocytosis is the increase in ferritin, which goes to beyond 100,000, and increase in liver enzymes. And it's been seen in all CAR-Ts, whether it is CD19 or BCMA. We in fact saw more MAS-like syndrome with the use of CS1 CAR-T. So patterns of relapse, I think it sort of follows this with the CD19 CAR-T approach. There are patients who don't respond, obviously, because you see that 80% initial response. And that's the ones that don't respond are called primary resistance. And it's you pretty much know in the first month when you do a PET scan. And similarly, you see the same thing in multiple myeloma. And of the responders, 80%, then you have 60% CRs and 20% PRs. And the ones who have PRs are the ones who relapse in the first 3 months. And the ones who have CRs, you have early and late relapses. So clinically, you can group them. And this is also very much the case in multiple myeloma. There are many reasons why this happens. One of the reasons is because of antigen escape or the internalization of the antigen or the suppression of the gene itself. So that's why you need to target other antigens in multiple myeloma, perhaps CS1, CD38, that might be of interest here. There are other products, other ways of doing CAR-Ts, which in a setting like India, I put these slides which might be helpful. And this is these are slides actually from Hari Parameswaran in Milwaukee. And he uses this homegrown apheresis machine, which actually happens in very rapid succession. And he actually is able to deliver live cells to the patient using this closed system of Miltony. And it's shown to work in lymphoma, and there are ongoing studies in multiple myeloma as well. Off the shelf is probably the way to go in the near future, only because of the timeline. If you look at the number of patients who get prepared to go on to CAR-T and who make it to CAR-T, there's at least 30% of them who may not make it. And so I think it's important that the timing is very important. If you have an allo CAR-T, you can get started with treatment within 2 weeks period. Without waiting for the cells to arrive, and you can start prepping the patient through that. So some of the things to be considered for myeloma particularly is the CS1 CAR, allo CAR, I should say, beyond the BCMA is one of the examples of an allo CAR, and that has been tweaked using TALEN technology as opposed to CRISPR technology to prevent it attacking its own NK cells, because fratricide has been known to occur. It's able to kill its own cells. So in summary, I think I'm going to stop here perhaps and be able to answer any questions. So we have seen dramatic responses in survival when treated with CAR-T, whether it's myeloma or lymphoma or leukemia. It's changed the treatment paradigm. That's great efficacy. There's a promise of lesser toxicity, I should say, a concentrated toxicity in the first 2 weeks, which are manageable. And it provides a depth of response. Yes, it's not superficial. Unlike a lot of antibodies, it's just you have to keep giving them treatments. It's just one treatment, and the immune activation is rejuvenated. Obviously, there are lots of combinations that are being considered with in myeloma, multiple myeloma, and even maintenance after this in patients who you think that might relapse. Obviously, this is a great effort, and our team of multiple myeloma and lymphoma in our department. A lot of acknowledgements go to Dr. Satman Ilapu, who actually spearheaded this CAR-T therapy. And today, I think we have due to his efforts, I think we have the 5th CAR-T approval in lymphoma. So, and training in India, in Bangalore, carrying the Bible of a bedside medicine, which is the Hutchinson's medicine. This is taken right out of that, from making the cure of the disease more grievous and the endurance of the same. Good Lord, deliver us. So with that, I'll stop and be happy to answer any questions.
Thank you, Dr. Swami, for the wonderful presentation. It was a very complicated talk in very simplified terms. I think there are a few questions. I think it was already answered, the time taken to engineer CAR T cells.
Can you hear me?
And will the lapse rate reduce with the third generation CAR?
Right. So all are good questions. I think the relapse rates perhaps will reduce. There is a whole thing that goes into the CAR T technology design. The third generation CAR T with the use of co-stimulatory molecule may or may not be the answer, because the amount of cytokine chemokine storm that comes out of it is probably higher. The other approaches are to use dual CARs, dual targets. So you have the CD19, CD22, you have the BCMA, CD38. In other words, you're able to reduce the antigen escape, and you have the right co-stimulatory molecule. What we have found is that the 41BB is also a good co-stimulatory molecule with reduced CRS effects, unlike CD28, which can stimulate the immune system very high.
I think if there are no more questions, we will end this session here. Thank you once again, Swami, for the wonderful presentation.
Thank you very much. Thank you for the opportunity.
Then we'll go for the next talk, that is by Dr. Nishad Agate, the role of daratumumab in multiple myeloma.
Hello, can someone share my slides, please?
Sure, sir. I'll share the slides.
So good morning, all of you. At the outset, I'd like to thank the organizers, Dr. Randeep Singh and Dr. Mahajan, for giving me this opportunity to speak on this very important topic, daratumumab in first-line treatment of transplant-eligible multiple myeloma. It's a very relevant topic in this 2021. I also thank Intaz and Janssen, who has provided relentless support in preparing for this topic. After we have heard Dr. Swami speaking about CAR T-cell therapy in multiple myeloma, which is probably the future for relapsed refractory myelomas, lymphomas, and ALLs, we'll be talking about daratumumab, the game changer in the last 2 years in the treatment armamentarium of multiple myeloma. So still, CAR T-cell therapy is elusive to a majority of the Indian patients. Daratumumab is easily available, and many of you have already had an hands-on experience in using this molecule. As we all know, daratumumab is an anti-CD38 fully human IgG1 kappa monoclonal antibody that binds CD38 expressing cells. And CD38 is highly and ubiquitously expressed on myeloma cells. Daratumumab binds to CD38 and induces tumor cell death through direct FC-mediated and indirect mechanisms, ultimately leading to myeloma cell death. It also has some immunomodulatory actions which contribute to the deep and durable responses. They actually promote and increase the CD8 positive, that is cytotoxic T cells, and lead to depletion of CD38 positive immunosuppressor cells. Next slide, please. So we all know that daratumumab is now approved for the treatment of multiple myeloma, both in the relapsed and refractory setting, as well as upfront. And it is also approved for the treatment of transplant eligible as well as transplant ineligible patients. It is approved as combination as well as monotherapy. In combination, it works synergistically with other IMiDs and proteasome inhibitors. Next slide. So this slide gives you the treatment algorithm of a newly diagnosed multiple myeloma. We largely divide them into two groups, transplant eligible and transplant ineligible. The transplant ineligible group receives primary induction, which may be a bit prolonged as compared to the transplant eligible group. And then there is a maintenance therapy. Whereas transplant eligible patients receive a primary induction chemotherapy of 4 to 6 cycles followed by a response assessment. And if that patient is transplant eligible, he receives a high dose chemotherapy followed by an autologous stem cell transplant. If the patient is refractory to induction, he could be enrolled in a clinical trial or therapy for previously treated relapsed refractory multiple myeloma. Next slide. So this slide shows you the various trials evaluating daratumumab in patients with newly diagnosed multiple myeloma. We'll be focusing today mainly on the Griffin Trial, Cassiopeia Trial, Perseus Trial, which actually included patients who are transplant eligible and where daratumumab was used in combination in an upfront setting. So in the Griffin Trial, which used daratumumab with the standard of care, that is RVD. So RVD plus minus Dara. In the Cassiopeia Trial, daratumumab was used along with VTD. So VTD plus minus Dara. And in the Perseus Trial, Dara was used in combination with VRD and Dara was used subcutaneously. Next slide. So coming to the Griffin trial, this was a randomized phase 2 study of Dara of RVD, which is the standard of care plus minus Dara in transplant eligible newly diagnosed multiple myeloma patients. This is an American trial where patients were enrolled in 35 centers across US from 2016 to 2018. The key eligibility criteria was transplant eligible newly diagnosed multiple myeloma patients 18 to 70 years of age with an ECOG score of 0 to 2 and a creatinine clearance of more than 30. It was a 1-to-1 randomization, and in the Dara arm, Dara was used as 16 mg per kg IV on days 1, 8 and 15, and RVD was the standard, lenalidomide 25 milligrams days 1 to 14, bortezomib 1.3 milligram per meter square weekly, and dexamethasone 20 mg. The RVD arm was the same. This was induction 1 to 4 cycles, which was every 21 days, which was followed by transplant. And then there were 2 cycles of consolidation, followed by maintenance, cycle 7 to 32. Interestingly, in this maintenance, they had used daratumumab 16 mg per kg IV day 1, which was given every 8 weeks or every 4 weeks, plus lenalidomide 10 milligrams and dexamethasone 20 milligram on day 1. The primary endpoint was stringent CR, which was assessed by the end of consolidation. And the secondary endpoints were MRD, CR rate, overall response rate, and VGPR. Next slide. So this slide shows you the post-consolidation depth of response, that is induction, transplant, and after 2 cycles. You can see here that the stringent CR was achieved in 42.4% of patients in the Dara arm, whereas 32% of patients in the RVD arm. And the odds ratio was 1.57. The p-value was 0.06. So this favored daratumumab. The depth of response was also higher in the daratumumab arm, which was 42.4%. and 32% in the VRD arm. So the overall response rate was 99% in the Dara arm versus 91.8% in the RVD arm. Next slide. This shows you that the responses deepened over time, and you can see the responses deepened in both the arms. However, there was a significant response in the Dara arm as compared to the Rvd arm. The response rates and depths were greater for the Dara arm at all time points. Next slide. So this cartoon shows you the most common treatment emergent side effects and infusion reactions. You can see the non-hematologic and hematologic side effects here. And the crux is that the adverse effects were more common in the Dara arm as compared to the Rvd arm. However, there were no significant deaths, and about 56% of patients had diarrhea and fatigue. About half of the patients had hypocalcemia, constipation. About 1/3 of the patients had nausea, vomiting, peripheral edema, pyrexia, and upper respiratory tract infection. So the treatment emergent side effects were common in the daratumumab arm, which comprised 94% of patients. Grade 3 or 4 treatment emergent side effects occurred in 88% of patients, but this included all the side effects which were very likely, probably, or possibly because of daratumumab. Grade 3 or 4 treatment-related side effects related to daratumumab occurred in 63% patients. Infusion reactions, as we know, are common and they occurred in 25% of patients. There were no grade 3 or 4 infusion reactions. Neutropenia and febrile neutropenia was the more common hematologic side effects. Next slide. This slide shows you the post-consolidation MRD negativity, and you can see that the MRD, the Dara arm had an MRD negativity of 44% regardless of response. This showed that the Dara improved MRD negativity rates at the end of consolidation. Next slide. This compares the side effects between the Dara and the Rvd arm. You can see that the side effects were slightly more in the Dara arm as compared to the Rvd arm. The any grade infections occurred in 82% of patients in the Dara arm, whereas 55% of patients in the Rvd arm. Pneumonia occurred in 10% of patients in the Dara arm as compared to 9% in the Rvd arm. Next slide, please. The authors concluded that DRVD improved rates of stringent response by the end of consolidation. The Dara arm improved MRD negativity at the end of consolidation. The combination was well tolerated and it was consistent with the known safety profiles of the Dara and Rvd. More grade 1 and 2 infections occurred with the Dara arm, but rates of grade 3-4 infections were similar. The stem cell mobilization was feasible and hematopoietic reconstitution was not impacted. Next slide, please. Now let's talk about the Cassiopeia trial. I will talk very briefly about this trial. This was a phase 3 randomized study of daratumumab with VTD. This was a French trial in patients with newly diagnosed multiple myeloma patients, phase 3 study, and they enrolled a massive 1,085 patients. The trial was a randomized open label multi-center phase 3 study, which was randomized 1:1. The eligibility criteria was the same as in the Griffin trial. They used daratumumab 16 mg per kg every week for cycle 1 and 2, and then every 2 weeks for cycle 3 and 4. VTD was as per standard. This was followed by autologous stem cell transplant and 2 cycles of consolidation. The primary endpoint was the same, stringent CR, whereas the secondary endpoint was MRD negative CR rate, and here they also included PFS and overall survival. Next slide. So their median follow-up was 18.8 months. The basic demographic characteristics were well balanced. Patients who discontinued study was 14% in the Dara arm, whereas 19% in the VTD arm. Next slide. So you can see here the post-consolidation depth of response. It was 29% stringent CR in the Dara arm as compared to 20% in the VTD arm. The odds ratio was 1.6, and this favored the addition of Dara to the VTD. Next slide. This shows you the response rates over time in the Dara and the VTD arm, and the response is deepened over time, and this also favored the daratumumab arm. Next slide. See, the MRD negativity was around 64% in the Dara arm as compared to 44% in the VTD arm. So the post-consolidation MRD negativity was significantly higher in the Dara versus VTD.
Nishant, can you sum up? I think you have exceeded the time.
Yeah. So can I go to the last slide of my presentation? Second last slide. I will skip this for time constraints. So in summary, the depth of response is an important prognostic factor in patients with newly diagnosed multiple myeloma patients. The Dara RVD improved the depth of response compared with RVD. The Dara arm improved rates of stringent CR by the end of consolidation. The Dara arm improved MRD negativity at the end of consolidation. The Cassiopeia trial showed us that Dara VTD therapy resulted in a robust clinical benefit that was both statistically significant and clinically meaningful compared with the VTD alone. There were no new safety signals were identified in the Dara arm, and this study supports the use of daratumumab as a frontline therapy in newly diagnosed multiple myeloma patients. Thank you, and I'd be happy to take some questions.
Thank you, Dr. Nishant. Since we are short of time, I think we'll for the panel discussion. The questions can be addressed during the panel discussion. And I invite Dr. Ajay Bave for the panel discussion on current management of relapsed refractory multiple myeloma. Dr. Abhay?
Abhay, sir, you'll have to unmute your mic. So you'll have to unmute your mic, sir. Sir, are you unable to unmute your mic?
Am I audible?
Rajesh, sir, you're audible, sir.
Yeah, right.
Abhay, unmute your mic.
Yes, there we go, sir.
I can unmute it now. For some reason, I could not unmute it.
Okay.
Can I share my screen?
Yes, sir. Yeah, please go ahead, sir.
Please go ahead.
Okay. First of all, thank you very much, Dr. Manoj Mahajan and the entire team of MOSCON who has made it possible for me to have this privilege of being the moderator for a topic which many of us will face in the management of multiple myeloma, and that's how to manage patients who have got a relapsed refractory state. And it was just, I think, serendipitous that when I got a message from Dr. Manoj Mahajan, I had a patient who was sitting across the table who had this kind of a situation, and I was seeing her for the first time. So in this panel discussion, I'm going to bring up a case study of a lady, and there is no hidden data that I have not given my panelists. I also don't know what to do for this patient, and therefore I'm taking this opportunity with this very august panel that I have been given, which includes Dr. Hari Menon. I hope he's on the panel. Dr. Rayaz Ahmed. I hope he's come on too. I know that Avinash is on the panel. Dr. Rajesh Patil, I don't know whether he's joined. I know that
I have joined.
Great. Dr. Akanksha Garg is there. And I don't know if Ganesh has joined in.
Sir,
but this is our panelists.
Sir, all panelists have joined except for Dr. Ahmed. He will try to join, sir.
Lovely. That's good news. Okay. So we'll get on with it. So relapsed multiple myeloma is a disease that meets the criteria for progression. But when it's a relapsed refractory multiple myeloma, it is a disease that progresses on salvage therapy or progresses within 60 days of the last treatment in patients who have previously achieved at least a minimal response. This is the definition. So I bring to you a case which I have not treated, but which I had the opportunity to look at as another opinion. This is a 74-year-old female who has hypertension, ischemic heart disease, and undergone 2 plasties. She was diagnosed as multiple myeloma in November 2012 at the age of 65. At that time, her bone marrow plasma cells were 30%. She had an M band, a kappa light chain, which was high. Apparently, there were no high-risk cytogenetics at that time, but I couldn't find a report. But she told me verbally that she was told that she didn't have high-risk cytogenetics. She was initiated on bortezomib and thalidomide. This is in the year 2012. She was given for 2 months, and then for some reason which I'm not aware, she was converted to a 2-year period of lenalidomide at 10 milligrams for 15 days a month. She took this for about 19 months, and there was a significant improvement of the light chains, although I don't have a report showing that it is normal. While on lenalidomide, she developed peripheral neuropathy, which was affecting her quality of life. And she also developed backache at that time, and they noticed that the light chains had again risen. At this point of time, her PET-CT scan showed increased activity in the D10 vertebra. So she underwent localized radiotherapy with significant reduction in the back pain. But after completion, the back pain again persisted, in fact increased, and therefore a spinal surgeon was consulted who took the patient up for vertebroplasty, which helped to reduce her back pain. However, at this point of time, from what I've read in the notes, there was a further increase in the kappa light chain to 783. And at this point, the len dose was increased to 20 milligrams with dexamethasone for 15 days of the month. And this she continued to take for a period of 2 years. In 2018, 2019, it was obvious that when her light chains were rising, she was put onto pomalidomide with dexamethasone, 4 milligrams. Every 21 days for a month. But despite taking this in a few months, I think it was about 6 or 7 months, there was increase in her disease process in terms of rise in the kappa light chain and bone pains. At this point of time, she was changed to melphalan prednisolone, which was given for 3 months, but she developed cytopenias, once needing transfusion, so that was stopped. In all these events, I have not seen a marrow examination report that was there for this patient. In April 2019, the kappa light chains went up to 2,190, and at this point of time, it was agreed to give her daratumumab with dexamethasone. It was given in the standard dose of 16 mg per kg weekly into 8, and then every 15 days for 8 doses, and then once a month for 3 doses. Unfortunately, by the time she finished this, the kappa light chains again rose, the free light chains, and there were new lesions in the pelvis on the MRI. Between September 2020, she received carfilzomib with cyclophosphamide and dexa. It is 6 cycles, not 12 cycles. But despite taking that, in February 2021, recently, that is last month, she had a rise in the kappa chain again to 3,600. She now was sitting opposite me with back pain and weight loss. So far, if you notice, she's received all 3 IMIDs. She's received radiation. She's had 1 surgical event. She's received a monoclonal antibody with steroid and carfilzomib in a triplicate combination. Only the first time at diagnosis, she had received a triple therapy. All the others, she received dual therapy, and then carfilzomib, cyclophosphamide, dexamethasone was the next triple therapy. The question she asked me was, if I had something to offer her in terms of treatment, then she will undergo the bone marrow examination, PET-CT scan, and genetics to identify what is the risk status. And my answer to her was that without these factors, it was hard for me to tell her how she was going to behave and how I should proceed, because she's had a significant exhaustion of her options. In a nutshell, this is what's happening to her. She did have a response with the first bortezomib-based therapy, where her light chains had come down to 7.8, but then subsequently it's always been high despite a significant amount of therapies given to her. So if you look at her patient characteristics, she appears to be a high risk because she's been relapse refractory. Her organ function was good except for a creatinine, which was 1.58. She had no, at least documented extramedullary disease, although I don't have a current PET scan. Initially, she had a good response, but subsequently it was all short responses to therapy, and she was progressing while on the current therapy. And the toxicities that she had were mainly peripheral neuropathy and cytopenias once needing transfusion. Her performance status was quite good. She came to my OPD walking, so she was quite good in her performance status. She has hypertension, she had ischemic heart disease, and now she's developing a mild hyperglycemia, needing an oral hypoglycemic agent. Her preference for treatment was something which put me on a little bit of a back foot, and I'm going to show you that. And her overall goal of care was to see that she was not troubled too much. Finances are not an issue. She has received daratumumab, so that itself gives you an answer. Her caregiver is a 3-year-old, her husband who's 3 years older than her, and a son who lives in the United States of America. Her son has called her there for CAR T therapy, but she doesn't want to go to the US because she feels by going there, she loses her independence. She's homebound and very dependent upon her other caregivers over there to be able to be mobile and active. I think that's a problem which most of the Indians face when they go to a Western world, where they are bound in their house. I might just give you another perspective. This patient has received a monoclonal antibody, and therefore, after a monoclonal antibody, if you're going to use carfilzomib, then if you're going to give it in combination, it might work in about 20% of cases. But if you're not going to use carfilzomib, the chance of doing well is very poor. She's already received carfilzomib in a triplicate combination along with cyclophosphamide and dexamethasone. So she has already had this therapy. And a second perspective, that those who have received a monoclonal antibody, either as a single agent or as in her case with dexamethasone, the chance of doing well is poor. So we're looking at a lady who has had 8 years of survival of multiple myeloma, undergone a penta therapy and failure of it with exhaustion of options. So I'm coming out to the panelists, and I'm happy for anyone to answer this as you deem fit, but just that we'll keep it as short as possible. Would you have done something different in this patient's therapy? Because predominantly it is doublets, except twice which is triplet. And before you answer, I'll just say, she asked me one question. Should I have done an autologous stem cell transplantation when I was initially diagnosed? She was 65 in 2013 when she had a very good response to the first line of treatment. So I'm happy for anyone to take over, or if you want, I can start with Hari.
Thank you, Abhay. And so looking at the sequence of events and the treatment protocols, everything about myeloma is proper sequencing of the treatment. Everything about myeloma is try to get the best responses available and also sustain those responses. Well, in some ways, she did get a good response, but starting with the, I'm left wondering why she was only given 8 weeks of therapy with bortezomib, and subsequently, whenever she had a relapse of the disease, bortezomib was never tried until now. A proteasome inhibitor has been tried with carfilzomib after a very long time. Secondly, the patient has been exposed to an IMiD for a long period of time, and it has been very clear that the responses with each use of each of the IMiD has not really translated into a sustained response, and except for the first time during the initial phase of treatment when she was put on thalidomide, and she had a fairly large response. Now, the only thing is that to me, the use of bortezomib should have been adequate to start with, and to answer a question about the transplant, she certainly should have undergone a transplant if she did not have any other comorbidities associated with it. And so you would have had a deepest possible responses. And then we have gone ahead and tried to increase the doses of lenalidomide to 20 milligram, which is probably not going to happen. And one should also always understand that even in the relapse refractory setting of a myeloma, a triplet regimen is always better than a doublet regimen. There's no doubt about it. So if you were to, then coming back to the third opportunity where monoclonal antibodies could be used for her, again, we have fallen back on a little bit of an inferior protocol of using just daratumumab with steroids,
wherein where clearly we know that addition of a second agent, depending upon what the agent she has been exposed to before, would have translated into a better response. And to me, using either bortezomib over here, or even for that matter, carfilzomib, may have been a better choice when using a monoclonal antibody. So to me, I think an opportunity of using the monoclonal antibody for better results has been lost over there.
Right.
And lastly, now she is we come into the third definition of relapsed refractory myeloma, where you have a relapsed myeloma which is refractory to any treatment. And when we have exhausted everything, and to me, the only thing that we may just, if she really doesn't want to go back or something, is to try the good old melphalan over here with steroids.
She received,
whether she can.
She received 3
Okay,
months of melphalan and she developed cytopenias.
I missed that. I missed that. Okay,
can we just say, yeah, sorry, go ahead.
So in that case, I would say that we have not left with many choices, and she has progressed.
So, Hari, we'll come to our choices. But I loved your analysis. I'll just ask Ganesh or even Avinash for that matter, that upfront transplantation, is the chance of then going into a refractory myeloma lesser?
This patient had 2 cardiac events and had angioplasty twice. I think the physician at that time must have taken that into consideration and cardiologist opinion. I'm not sure about her status as of now, because even now I would have been wary of using carfilzomib in this patient. So upfront transplant, if it was assessed and it was given, in that case, definitely the possibility of staying in PFS and OS is increased, but still the chances of development of resistance to the maintenance lenalidomide or bortezomib, depending on the risk factors. In this patient, there was no high risk. So would have been there. And then refractory patients, again, you have to follow the same path of going ahead with the triplet with monoclonal antibody and others. So post-transplant refractoriness also is likely. And in this patient, why transplant was not done is not explained, but possibly the cardiac issue was the reason.
Okay, so Ganesh, you have anything more to offer? Other, I'm going to go to the next question to ask my next panelist.
Just from my perspective, a myeloma diagnosed at the age of 65 years. Whatever sequencing of various available drugs has been done in this case, she is almost in the 9th year of her survival, whether we do transplant or not. The median survival with transplant is also 5 to 7 years. So she has, beyond our expectations, despite her repeated relapses, progressions, she has been doing quite reasonably well. For a myeloma of 65 years, now she is into 74th year. So I think sequencing depends not only on the patient's related factors, but there must be many factors at that point of time that the treating oncologist might have considered. And looking at her history, the bortezomib was tried only for 3 months in the beginning. So there must be some toxicity. So the circumstances
Can I just remind you that this is 8 years of not a great quality of life. Huh? She's been in and out of hospital. She's had surgery. She's had neuropathy. So it's not been a great 8 years, and we've got 8 years also without with or without transplant.
Yes, sir.
More so with even transplants. So that's another perspective. I'll just give you one more perspective. If you look at the Aspire data for carfilzomib, when you use carfilzomib after the first line treatment failure, the overall response and the progression-free survival and overall survival is a little bit more superior than when you use it much later. So, when we have carfilzomib available as a generic agent, using it in the second line rather than waiting for multiple relapses might be a better option in our country than using it much later. Okay, having said that, I'm going to go to my next question. I want Dr. Akanksha Garg, Rajesh Patil to be able to give me some information on this. She's sitting in front of you. How will you counsel this patient now? Is your intention still to treat her? Her performance state is quite good. Or will you now tell her that, look, you've exhausted everything. It's better to you take palliative. Now, what does she want? I told you what her treatment goals were. She wants to be treated from home, preferably oral medications with the least side effects and a quality of life that will allow her to do her routine work and not interfere with it. So what do you all think?
Yes, sir. So Akanksha here. So since this particular patient, she wants to be treated right now, So I would not discourage her, but given the fact that many of the options have been exhausted, but I would like to say that many of them have not been given in the proper dose or in particular combinations. So as per the previous history, she was sensitive to chemosensitive to lenalidomide also, as well as bortezomib was given in combination with thalidomide, but because she developed peripheral neuropathy, that drug was stopped. So probably she can be given a re-challenge of bortezomib again in combination with either lenalidomide and dexamethasone, or we can give a combination of daratumumab with Revlimid and dexamethasone for this particular patient. And given the fact that she's
received a fair amount of daratumumab and she's progressed while on it, and she's had a peripheral neuropathy. So using len and bortezomib again is going to be a problem. She's already used carfilzomib and she's progressed while on carfilzomib.
So then, sir, the other options would be, but given her age now, she's probably reached 75 years of age. So obviously CAR T cell therapy or a BCMA therapy would be one option, but
we'll come to that. So that's one option. We'll have to keep it in mind. Any other thoughts?
For oral therapy, the one which is available in India, but which I will be wary of using in this patient, but for the sake of discussion, is panabinostat, along with other two drugs. And exazomib, if it would be available in your future, would be another oral therapy sitting at home.
Excellent. Yeah, those are two great choices. Panabinostat is available in India, and panabinostat with carfilzomib.
So I just wanted to. Interrupt, but I just wanted to use panabinostat for a patient. It is no longer available. It's stopped manufacture in India.
MQR had it, if I'm not mistaken. Okay.
It is no longer available. It's no longer available. Yeah.
The problem is the diarrhea. The diarrhea is the Rajesh, any thoughts about counseling this patient? How would you go about it? Is Rajesh there? Have I lost Rajesh? Okay.
Rajesh, sir, you'll have to unmute your mic, sir.
No, sometimes. Yeah, Rajesh, please.
I think the bone marrow transplant at the initial stage is a very good option. That is the question probably all the panelists will agree. And beyond that, there we can see that broadly there are two subsets of patients. One who very promptly respond to the initial line of treatment they are offered, and they remain in remission for a quite long time without any further events. However, we know that the real problem or challenge is set by the second set of patients who either do not complete the first therapy or do not properly respond to the first initial therapy. The same thing can happen to the next therapy, and they are the one prototype that is being presented by the real panelist. So these are the patients who pose the challenge, and we have to try with the permutations and combinations and go on trying. And
okay, great. So Rajesh, can I then ask the next question that to my panelists, that if in an Indian context, you know the situation now. She does want treatment, but not with too much damage to her body. And she's not going to go to the US. She's going to stay with you in India. So now what would be your drug of choice? I think Akansha did mention that she would want to give some of the earlier drugs again in a more longer duration, but she's already had some side effects to it. So in this context, what would you, has Dr. Ahmed joined in, or he's still off the panel yet? If he's on the panel, I'll be happy to listen to him.
Sir, he's not there on the panel, sir.
Yeah.
You can. So the only thing that I can consider is that probably the cytogenetics, even if she has done before, I mean, we are looking at options over here. So the cytogenetics that was done way back, and which was just a verbal comment, and perhaps not even done on cell-sorted cells at that time, it may be well worthwhile to see whether something can be thrown up in terms of cytogenetic abnormality, and if there is something like 11-14 translocation or something, then we could just think about using venetoclax, which is available in India, because the data from Shaji's group clearly demonstrates a benefit for that subgroup. So one may want to look at it, especially because she's not keen on.
Yeah, we'll come to that. So Avinash, you wanted to say something?
Yeah, only remaining drug other than venetoclax available in India is bendamustine.
Yeah. So I would like to ask the panelists any thoughts on using of, has anyone used bendamustine?
It has been, there have been regimens, but it is not such a, it's only something like a transient response. And in this, but in her case, given that she has had a lot of toxicity in terms of neutropenia, even with melphalan, I suspect that she will not tolerate bendamustine over here. And as such, she must be in a relatively immunocompromised state because of the previous antibodies received and also the active myeloma that is present. And you must understand that bendamustine is profoundly immunosuppressive in several ways. And doing that, while we can use it, there is going to be a suspicion regarding how well she tolerates that.
Okay. So I looked up some of the data. I have not used bendamustine myself. Has any of the other panelists used bendamustine?
Occasionally, off and on, when we do not have any other choice.
Okay. Akanksha, Rajesh, anyone else has used?
Sir, no, I have not used bendamustine, but I'd like to suggest, what about a combination of pomalidomide with cyclophosphamide and dexamethasone? Because initially he has received.
Yeah, the PCD protocol is good, and I think the MSMART from Mayo also suggests that for high risk we can still use it. But she's already used pomalidomide at full 4 milligrams for a significant period of time, and she progressed on it. I was just looking at bendamustine. These are 3 nice papers on bendamustine. I'm sorry for this slide. It looks a bit hazy. I tried to make it as clean as possible. If you leave the last 2 columns, which are untreated multiple myelomas who received 90 milligram per meter square of bendamustine, along with bortezomib and dexamethasone, all the others on top have received between 50 and 70 milligrams per meter square of bendamustine. You will see in combination with bortezomib, you will see that the response rates are not bad, but going into CR is not the best. But still, we are getting an overall survival of somewhere between 13 to 20 months. So as a palliation to buy time, bendamustine may be good in treated relapsed refractory patients. When we are faced with a situation where we are still thinking we don't have drug, we want to buy time, that may be a good option. And the last 2 columns you'll see in untreated, there's a difference. In the ages of 60 and above, also, the responses were much better and the CR rates were also much better. And you look at the overall survival, that was quite encouraging at the end of 2 years. So, for people who really can't afford too much of these MABs or other higher generation proteasome inhibitors, I wonder for India whether this will be a good option. But I'm going to go ahead with the next question. And that is, what would be your drug or drugs of choice in this situation if you were to treat her with trial drugs available for her like in the West? So Avinash, you want to take it on first?
Yeah. Actually, there are a good number of drugs which are not available with us, which includes exasomib, which is a proteasome inhibitor. But there are other monoclonal antibodies also, like inotuzumab and isatuzumab, the daratumumab, and the newer ones, the BCMA inhibitor like belantamab and selinexor. So these are the drugs which are remaining. And there is no one-to-one comparison or trials saying one is better than the other. But in multiple myeloma, as a rule, we go on using one after another till we exhaust all the options. And once we are provided with these options, we will try in these patients.
Right. Rajesh, Akanksha?
The selinexor, I'm not very sure because I think it has a lot of toxicities associated and considering her age also. So if I had an option, then elotuzumab and maybe the other, the isatuximab monoclonals could be tried in this particular patient. And then, of course, we have the anti-BCMA, the belantamab, because some of the studies have shown, the DREAM studies have shown that even almost 40% of the patients who were between the age group of 60 to 70 years of age. But obviously, we have to look out for the eye toxicities.
Yes, so can I just ask the panelists that, we've all spoken about these drugs, we listened to them on various webinars. So in your reading, which is the drug or the therapy that has impressed you most in this situation? So should we start with Hari? Just a quick answer as to which
I think targeting the BCMA Targeting the BCMA is something that has been impressive. And if you set aside CAR T cells using the bispecific antibodies targeting the BCMA, like belantamab, can be an option if it is available. That is something that is impressive because it's a different target altogether that we can look at.
Right. Avinash?
Yeah, nothing more to add. Agreed.
Rajesh?
Actually, I don't have any comment on this. Thank you.
Ganesh?
Yes, sir. Agreed.
Right. So I think Akanksha has alluded to the fact that selinexor, which is oral, has some side effects of nausea and thrombocytopenia. And belantamab is making a lot of waves as a BCMA target. And we had a beautiful lecture by Swami just now on targeting BCMA with CAR T cells. But that also has certain toxicities, which can be a problem. But then having the disease in a relapsed refractory state is also a problem. And therefore, if we have to get out, we might have to face some of the side effects and then get on with it. Coming to CAR T. Now, we are very proud that 3 of our colleagues, hematologists, are working on CAR T, the Indian CAR T. And we'll be very happy. And I've had the privilege of listening to all 3 of them on a webinar, which we had done about 6 months ago. And it's encouraging to know that all 3 of them actually have left practice to just concentrate on CAR T. Hats off and kudos to them. And we are hoping that from what they had said, that about 3 to 5 years down the line, we might also have a formal working Indian CAR T, which might make a difference to our patients in the management of multiple myeloma. And as alluded to already by Swami about the various CAR Ts and its generations, these are the lentivirus vector with the co-stimulatory domain CAR Ts, which have been studied. And look at the overall response and the progression-free survival. It looks very impressive for those who respond, but unfortunately, there are reports of relapses even after CAR T, and therefore, I think there is an element called CAR T exhaustion or cell exhaustion. So we may have to use some immune checkpoint inhibitors to clear up the milieu interior, the microenvironment, before we give the CAR T. And that might make a huge impact in the management and prevention of relapses when we are using CAR T.
2 minutes left, sir.
Yeah, I'm coming to my last question. I'm timing myself. I've actually got 6 minutes as per my timing, but it's fine. The last question, if I told you that there was 1114 translocation, I think Hari has already mentioned it, and he has mentioned the term venetoclax. So Ganesh, you, Avinash, Rajesh, have any thoughts? Akanksha, have you all faced 1114 in your practice in myeloma?
We have faced, but we have not used venetoclax. What we know theoretically is that venetoclax is the option in these patients when all others are not options available. It will be an off-label use, and do not venture to try venetoclax in other translocations where it can be more detrimental. So 1114, when all exhausted, off-label use of venetoclax is allowed.
Yeah, so there is data that when there is an expression of 1114, especially with a high BCL2 expression, then it's a very attractive option to use. And I think Hari mentioned about the Bellini trial, which Shaji Kumar had done, of the addition of venetoclax to bortezomib plus dexamethasone. It significantly improved the progression-free survival. There was a higher mortality because it is very narrow-centric, this venetoclax. Therefore, the increased mortality was there, but the greatest progression-free survival was seen with venetoclax when patients had 1114 with BCL2 high expression. So here, this is the cohort I think you're talking about, Avinash, which will do very well. And I wonder whether we should wait for multiple lines of treatment. If we pick this up earlier, maybe using this earlier, like it was presented earlier about using daratumumab upfront, it might make a difference to use venetoclax earlier if we show that this 1114 translocation exists and not for the other translocation. So I'm going to come to the end of the discussion, saying that whenever we treat patients of multiple myeloma who are relapsed refractory, we look at disease characteristics, what has been the therapy and the response to it, what is our patient's criteria and patient's needs, finances and caregiver, extremely important. I run a multiple myeloma support group with Dr. Tapan Saikia, Shashi Apte, and 4 other patients called MFCT. And for the last 5 years, we have been taking care of the caretaker and the patient, giving them information. But I've always found the difficulty in making a decision in these patients, because sometimes the expectations are high and we don't match up to it, or we can't match up to it. It's a very individualized thinking with the patient who's sitting opposite you, how to treat him or her in the future. And it needs a lot of time spending and counseling to be able to make them understand, what is going to happen in the future, and you're not in control of the disease process. So I'm going to conclude this session and thank my panelists for being so candid and open about their comments. And maybe for this patient, as a bottom line, I might offer bendamustine as a holding measure till I'm able to convince her to go to the US for CAR-T therapy. Any other thoughts before we give the podium back to the organizers? Any last comments from any of my panelists?
Sometimes we have to suit the therapy as per the patient's needs, as you are rightly said. And mostly we are fortunate to practice in India because most of the patients, they do not cover under the insurance. And we don't have to follow strictly the protocols which are necessary to be followed in the countries like US. And we can individualize the therapy which is not given in the books or which is not followed, and we can give the best possible treatment to our patients depending upon their need and their budget.
Thanks, Rajesh. Thank you very much. Anyone else? Ganesh, your thoughts? Avinash?
Well done, Abhay. That's all.
About the patient. Okay, fine. Okay, so if there are no more, thank you very much for these beautiful comments, and I'm hoping to give some information back to my patient, and I hand it over back to the organizers. Thank you so much.
Thank you.
Thank you so much, sir. Thank you to Pavitran sir as well. And on behalf of the organizers, we would also like to wish Pavitran sir a happy birthday in advance. It's his birthday tomorrow.
Well done.
Many happy returns of the day.
So we'll now move on to our next session. The next session is on leukemia. Our first speaker is Dr. Sameer Tulpule, who's an hematologist from Mumbai. Without wasting any time, so with your permission, I will share the screen.
Yes, please.
Yeah.
So thank you very much for the invitation. I'd like to thank the organizers for this meeting, and we had a very spirited discussion about in the previous myeloma session. I think excellent. I think we're short of time. So without wasting too much time, we've probably just got about 8 minutes to speak. So I'm going to speak about this phase 3 study of using sorafenib post-transplant in patients with FLT3 AML. This is based on the findings, retrospective findings, that sorafenib maintenance post-transplant might reduce risk of relapse, especially in patients with FLT3 positive AML undergoing an allotransplant. And previously, the same authors had investigated the efficacy and tolerability of sorafenib post-transplant in this population in a phase 1 trial. Now, just a little background. This is a trial which is done around 7 centers in China. In 2016-17, I think a similar study was done in the US, which actually with a smaller population, but actually confirmed this concept. Next slide, please. Now, this was an open label. It was a randomized phase 3 trial because previous data was phase 2, but this is a phase 3. So we have got randomized between patients who have had sorafenib maintenance versus those who have not had sorafenib maintenance. So eligible patients 18 to 60, FLT3 positive AML, had an allotransplant, ECOG performance 0 to 2. They were in CR before and after transplantation, and hematopoietic recovery within 60 days post-transplant. Next slide. They were excluded if they had APML or their previous intolerance to sorafenib, or physicians deemed life expectancy less than 30 post-transplant, active uncontrolled infection, active acute GVHD, and other concomitant severe organ dysfunctions like cardiac, liver, renal, or psychiatric. If they had these, then they were excluded. Next slide, please. Now, they were randomly assigned to receive sorafenib maintenance 400 milligrams orally twice a day versus no maintenance. Now, the sorafenib dose was then, after randomization, was then left to the physician to decide whether they can reduce the dose depending upon side effects or organ dysfunction, or even hold it for a couple of days and then restart. The primary endpoint here was 1 year cumulative incidence of relapse in the intention to treat population. And the secondary endpoint was, adverse events, overall survival, leukemia-free survival, non-relapse mortality at 2 years. Next slide. Now, this is the overall schema. So they had about 200, if you go right at the top here, they had 227 patients with FLT3 who received a first allo transplant. 25 were excluded for various reasons of not meeting the criteria. Finally, 202 were randomized, 100 to the sorafenib arm, 102 to the maintenance arm without the sorafenib. Now, a point to make here is in this sorafenib maintenance arm, 59 had already received sorafenib as part of their induction before going to transplant, and a similar number in the no sorafenib maintenance group as well. So equal numbers in both the arms before going into transplant. And then equally randomized, so equal numbers between 100 and 101 in the sorafenib and the non-sorafenib arm. Next slide, please. Now here the median follow-up post-transplant was about 21 months. What they found was they had a relapse in about 43 patients, 11 in the sorafenib arm, 32 in the control arm. The time to relapse, median time to relapse, was 11 months in the sorafenib arm and 5.7 in the control arm. So we see about half the time, or so twice the time required in the sorafenib arm. The 1 year cumulative incidence of relapse was 7% in the sorafenib group and 24.5 in the control group. So that's quite significant. Next slide, please. Of the 43 relapses, 22 were at the time of relapse. Now, this is at the time of relapse. 22 had FLT3 mutations, 1 had a TKD mutations, and 20 actually were wild type. Out of those 43 patients, 36 received salvage, 9 from the sorafenib, 27 from the control. If we divide them, 6 had sorafenib plus chemo and 30 had sorafenib plus chemo plus DLI. Out of those, almost 58% achieved a CR, sorry for the spelling, equal in both arms, with the 1 year survival around 45% in both arms. So still salvageable if they've had treated with sorafenib. And there were about 5 deaths. There were 20 deaths, I think 5 in the sorafenib and 15 in the control after the salvage. Next slide. Now we go back to our primary cumulative incidence of primary endpoint, cumulative incidence of leukemia relapse. So now we see, okay, now we're not seeing this here. So blue is the sorafenib group and red is the control group. The horizontal line at 12 months, you can see roughly, sorafenib is about, less than 10%, whereas the control group is almost 20-25%. If you go to 2 years now, the other vertical line, we can see that is again around 10% for about sorafenib, whereas this has now grown to almost 30-35% in the control group. So I think the response is still maintained in the sorafenib arm, even at 2 years. Next slide, please. Now, when we go to overall survival, the same thing again. At 1 year, we're looking in the sorafenib, survival in the range of sort of 85-90, that sort of range, and about 70% at 1 year for the control group. And at 2 years, that's going to roughly about maybe 65-70 in the control and about 80% in sorafenib arm. So clearly, a survival benefit as well by adding sorafenib. Next slide, please. When we look at leukemia-free survival, there's a big difference again here. At 1 year, we're looking at almost 62% leukemia-free survival versus upwards of 80, 82, 83% for sorafenib. And 2 years down the line, it's less than 60%. Sort of, we would say about 58% for control and just below 80%, maybe 78% for the sorafenib. So quite good leukemia-free survival as well. Next slide, please. Now, this is quite a busy slide. Now, this is a subgroup analysis for relapse at 2 years. And there are 2 major groups, sorafenib and non-sorafenib maintenance. If you look at the plot on the right, you can see that all those plots to the left favor sorafenib and to the right favor control. And they've looked at various parameters, gender, cytogenetics, MRD, CR status. And in all those categories, sorafenib maintenance has favored the patients in terms of incidence of relapse, so lower incidence of relapse at 2 years. Next slide, please. So the overall findings at 210 days post-transplant, the most common grade 3 side effects were infections, acute GVHD and chronic GVHD, sort of similar in both the arms. But when we come to hematological toxicity, you had 15% in the sorafenib arm, 7% in the control arm, which means sort of more hematological toxicity in the sorafenib arm. Next slide, please. So they summarized to say that sorafenib maintenance post-transplant can reduce relapse and is well tolerated in patients with FLT3 AML undergoing an allotransplant, and this strategy would be a suitable therapeutic option for FLT3 ITD AML. Sorry, I think that was my last slide. I've really rushed through in the interest of time, but I think it's particularly important for our Indian population because now we have got two drugs. One is midostaurin, which we can use quite a lot of people have been using midostaurin, and now post-transplant, especially sorafenib, which we've got now good data. So I think our FLT3 AML patients have now got good choices to use these molecules for better outcomes. Thank you.
Thank you, Sameer sir, for the wonderful presentation. We'll now request our next speaker, Dr. Varun Bafna, who's a hematologist from Kolhapur, to please go ahead with the next topic. Over to you, sir. Varun sir, you'll have to unmute your mic. So till that time, if we have any questions for Dr. Sameer, we can take that.
Yeah, I'm Dr. Anant. Can I ask a question?
Yes, sir. Please go ahead, sir.
Yeah, hi. Hi, Dr. Sameer. It's a very nice talk. I just wanted to ask although sorafenib in the SOR AML trial post in upfront setting did not actually show a survival benefit, only PFS benefit, but in the post-transplant setting, it seems to be having a very good response. What do you think? Is it a different mechanism, or is it just the anti-TKI effect, or is it also kind of stimulating the GVL effect that is giving it kind of a more potency in the post-transplant
it's a good question. Good question, because we all remember that previously there was some data and all of us tried to use sorafenib, but without much success. But especially in the post-transplant setting, I'm not quite sure, but I think I was reading that there's some, the GV post-transplant, I think there is probably maybe some augmentation of the GVL, probably through mechanism still unknown, or maybe there is some better sensitivity of the kinase inhibitions, because we know it does affect the RAS and the other pathways, the KIT pathways, all the other pathways involved in the mechanism. Maybe that could be one of the effects, but to answer a question, not quite sure.
And what is the dose that you use? I mean, we have used sorafenib in few post-transplant setting, and many of them had a lot of toxicity.
Correct.
One patient had severe TTP, other had nephrotoxicity, proteinuria, and renal toxicity.
So as I said here, the trial started with 400 BD dose, but they have gone down to as low as 200 OD as well, depending upon the tolerability of the patient. So I think it is left to the individual. Sorry.
Sorry, sir. Sameer sir, please go ahead.
Yeah, so it was sort of left to the Indian physicians to do. So what they have not been very clear in the paper. It's actually a very good paper to say how many patients of those who responded were at what doses in terms of tolerability. They have said grade 3, grade 4, grade 3, grade 4 neutropenia and things like that, but they haven't been very clear of, out of those 100 patients, how many patients, what the patients were on what sort of doses, or what was the commonest or the median dose or the more dose that patients received. So that is just in one paragraph. So that is not very clear.
Right. Thank you.
Thank you so much, Samir sir, for answering that question. Varun sir, are you able to unmute your mic now, sir? हाँ वरुण सर
अच्छा मेरे को वहां से नहीं आ रही आवाज
sir are you able to hear now sir Varun sir are you able to hear me sir आपकी आवाज आ रही है सर Mrd to please speak on the next topic. Over to you, sir.
Okay. Is my screen visible?
Yes, sir, your screen is visible, sir.
Okay. So I'd like to thank Dr. Mahajan and team Moscon for inviting me. I'm going to speak on role of PI3K inhibitors in CLL. So I have 15 minutes to speak. If we see the treatment landscape of CLL in last 1 decade, there are lots of new molecules which got approval. And if we see here that trend is changing from chemotherapy to targeted therapies. So 2 of these molecules, idelalisib and dualisib, are PI3K inhibitors, which were approved in 2014 and 18 respectively. And even though these agents are approved, they are still struggling for its place in management of CLL for specific issues, which we will see in this talk. So all the targeted therapies in indolent B-cell lymphomas and leukemias, they try to target one of the point in this B-cell receptor signaling pathway, because it is very crucial in pathogenesis of these malignancies. So for CLL, it's quite important in its pathogenesis. So signaling is mediated in part by activation of delta isoform of PI3K. PI3K has 4 isoforms, alpha, beta, delta, and gamma. And PI3K delta is highly expressed in lymphoid tissues, and it activates AKT and mTOR pathways, through which it has effects on cell metabolism, migration, proliferation, survival, and differentiation. So we can see the PI3K pathway here and its downstream pathway. There are a number of molecules already developed, and few of them are already approved for management of different indolent lymphomas. For PI3K, the earlier molecules were not specific. They used to inhibit all the isoforms, but the drugs which are approved like idelalisib, it is delta isoform specific, and dualisib is delta plus gamma isoform specific. This was the first paper which got approval for idelalisib in relapse refractory CLL. It was a multi-center trial, included 220 patients, 110 in each group. Median age was 71 years. They all were previously treated with at least 3 drugs, and 90% of them received rituximab or other CD20 monoclonal antibody. Majority had myelosuppression due to prior chemo and decreased renal function. 80% of these patients had unmutated IGHV, and other 40% had deletion 17 or TP53. So overall, this was a group of elderly CLL patients with lots of comorbidities and high-risk disease biology. They were randomized to either rituximab plus idelalisib in the dose of 150 milligram twice a day versus rituximab plus placebo. So if we see the results for progression-free survival, idelalisib was significantly superior. At the time of this publication, PFS for placebo group was only 5.5 months, and it was not reached for idelalisib group. But in the final results of this study, which were published in 19, they reported PFS of around 20 months. Overall response rates were superior for idelalisib group of 80% versus 13%, and OS was also better for study drug, that was 92% versus 80% in placebo group. If we see the lymph node response, each line here represents one patient. So idelalisib group, almost all the patient had some response in their lymph node size, with 10-20% achieving CR, and none of them progressed during the study, which was around 12 to 14 months. In contrast, patients receiving only rituximab had a definitely lower response compared to the study drug, and few of them even progressed during first few months of rituximab therapy. If we see the response in lymphocyte count, like Brutinib, patients receiving PI3K inhibitor had initial period of lymphocytosis with rapid decline after rapid declining lymphocyte count, and duration was sustained at least for 48 weeks. And in rituximab group, there was rapid decline in lymphocyte count, but which was not durable over the time. Subgroup analysis of these patients. So it seems that PI3K inhibitor is working even for high-risk patients with IGHV unmutated status, deletion 17, and TP53 mutation. For almost all the subgroups, idelalisib was better compared to rituximab plus placebo. So as we already discussed, that lymphocytosis also occurs with use of PI3K inhibitors. But here it was used with rituximab. So rituximab blunts the response and it shortens the duration of lymphocytosis. It peaks at around 2 weeks and usually resolves by 8 weeks. No specific treatment is required for this. The second agent is duvelisib, which is a dual inhibitor of delta and gamma isoform. So delta inhibition, as we already discussed, it blocks survival and proliferation of malignant B cells, while inhibition of gamma isoform disrupts recruitment of T cells and macrophages to tumor and microenvironment, which are very crucial in maintaining CLL microenvironment. This was the phase 3 duo trial, which compared duvelisib versus ofatumumab, which was already approved drug for relapsed refractory CLL at that time. They were randomized to in 1:1 ratio, and the dose of duvelisib was 25 milligram twice a day. The patients here were patients who progressed after or progressed relapsed after at least one previous line of therapy. If we see the result, progression-free survival was significantly better for duvelisib compared to ofatumumab, 13 months for duvelisib versus only 9.9 months for ofatumumab. Even for overall response, duvelisib was better compared to ofatumumab, 74% versus 45%. Again, in subgroup analysis, we can see that this PI3K inhibitor also works for bad disease biology like 17 deletion, TP53 mutation. Even patients with early relapses, refractory disease, and cytopenias at baseline, duvelisib appears to be work better compared to ofatumumab. So with this, both these drugs got approval for relapsed refractory CLL patient. Now, the first problem and difficulty in its use is its toxicities, because even though these inhibitors are quite specific for delta and gamma isoforms, they are not 100% specific. And other isoforms like PI3K alpha is ubiquitously expressed, and its inhibition can cause hyperglycemia, hypertension, nausea, vomiting. Beta is also ubiquitously expressed. Its inhibition causes diarrhea and nausea. Gamma is on leukocytes. Effect of inhibition is not known. And most important one is inhibition of delta isoform, which is crucial for to control the CLL, but at the same time, it can cause transaminitis, diarrhea, colitis, pneumonitis, which is mostly related to immunological effects. So if we see the real world data for idelalisib, almost 24% patients required dose modification, 50% required dose interruption, and 42% had to ultimately discontinue the drug because of its toxicities. Same for duvelisib in phase 3 trial, the toxicities were seen were almost 15 to 30% patient developed some hematological toxicities, mostly cytopenias. If you see the incidence of diarrhea, almost 50%, and 15% out of them had grade 3 diarrhea. Other significant side effects were pneumonia, colitis, bronchitis, other GI symptoms, and hepatic dysfunctions. So immune-related events which we have seen are colitis, hepatitis, dermatitis, pneumonitis, and pneumonitis. And it is thought that most of this inhibition is due to PI3K delta inhibition in T lymphocytes. And when this inhibition preferentially targets T regulatory cells, so while these T regulatory cells are suppressed, there is uninhibited action of CD4 and cytotoxic T lymphocyte, which causes this immunological side effects. And usually they are responsive to, these effects are responsive to corticosteroids, which is again an indirect evidence that these adverse reactions are immune mediated. Infections are also quite common with the use of PI3K inhibitors, but two specific infections we need to be careful about. First is pneumocystis. Prophylaxis is recommended for all the patients receiving PI3K inhibitors. CMV reactivation is also quite frequent with PI3K use, so monitoring and subsequent management is advisable. So the first problem is toxicity of this drug, and second is availability of other novel oral therapies. And it has a strong competition from BTK inhibitors, Brutinib and Ecalabrutinib. Both drugs are approved for relapse refractory CLL and also for treatment-naive patients now. This drug produces high response rates, durable response, and well tolerated as a monotherapy compared to PI3K inhibitors. The second one is venetoclax, which it causes very high response rates, very rapid response, and it has high activity even in high-risk CLL patients. So there is no head-to-head comparison of PI3K inhibitors with either ibrutinib or venetoclax, but there is a large retrospective multi-center study which included 680 patients. So if we see the comparison of ibrutinib and idelalisib in frontline setting, PFS was significantly better for ibrutinib. Even in relapse refractory settings, ibrutinib is definitely better in terms of PFS. Now, interestingly, when patient fails ibrutinib, if you see the data of idelalisib versus venetoclax, here venetoclax is significantly better. So to overcome these issues of toxicities and less efficacy compared to other novel targeted therapies, there is a need to develop next generation PI3K inhibitors, and few are already in pipeline. Umbralisib is already in phase 3, which is completed, and it has already been approved for other B-cell malignancies, mostly marginal zone lymphoma. It has a higher specificity and probably less side effects. Second molecule is zendelisib. The second solution to reduce the side effect is optimizing its dose schedule. So intermittent dosing, by which we assume that it will allow the T regulatory cell recovery and help in decreasing immunological side effects, which was tried in zendelisib trial, and data is yet to come. Even the combination with ibrutinib and venetoclax trials are going on. So to conclude, inhibition of PI3K results in significant anti-tumor activity in CLL, but the toxicities of current generation PI3K inhibitors and availability of other novel therapies are the barriers for its use. But still, it has an important role in patients progressing after BTKI inhibitors or BCL2 antagonists, particularly when patients have comorbidities like cardiac failure, where ibrutinib is difficult to use, and renal dysfunction, where venetoclax could be difficult because of its tumor lysis syndrome. And the newest concept in treating CLL is to develop fixed duration combination of novel therapies to reduce its cost, duration, and to achieve deeper remission, where definitely PI3K inhibitor can be incorporated. With this, I end my talk. Thank you very much.
Thank you so much, Abhishek, sir, for the talk. So now we'll just move on to our previous talk. Dr. Warren, are you able to hear me? So till that time, if you have any questions for Dr. Abhishek, I request. Yes, sir. Are you able to hear me? Hello, Dr. Warren. Dr. Warren, can you hear me? Yeah, yes, sir.
Yeah, I'm able to hear you.
Yeah, sir. Would you like me to share the slides, sir?
I'm able to hear you. Yeah.
Yeah, sir. So can we start? Yeah. So you'll have to mute one of the mics, sir. So you'll have to mute one of the mics. Both mics are on currently, sir. So you can unmute your mic on your phone, sir. Yeah. Yes, sir. Sir, can you say something?
Yeah, I can hear you now.
Yeah. So can I share your slide, sir?
Yeah.
So thank you so much, sir, for joining us at this last moment. And without wasting any time, I would request you to start your lecture, sir. Thank you, sir.
Yeah, thank you, organizers, for inviting me. Yeah, I can understand it was the last moment, but still I try to manage few of the slides to discuss. There's a IDH mutations for the AML, what we are going to discuss it. Yeah, basically the IDH mutations, what exactly it is, key everybody is, it's in this IDH is isocitrate dehydrogenase enzyme. That is basically a metabolic enzyme integral to cellular respiration. Basically in the Krebs cycle, everybody is aware, TCA cycle, what we say. So it has it usually binds to the isocitrate and helps in conversion to isocitrate to alpha ketoglutarate. And whenever the mutations occur at the IDH1 and the IDH2, and that leads to formation of the oncometabolite, that is 2-hydroxyglutarate. And this is known to cause all the notorious thing with the histone demethylation and various further issues, whatever we are facing, the AML mutations. How this IDH has been developed? What are the key research milestones? Basically, IDH1 mutation is identified in the glioma in the 2008. Then after that, it was just it was newly detected in the AMLs. But how it was functioning, it has completely in detail. It has come by 2010. Then it has come to know by that oncometabolite, which is hydroxyglutarate, that inhibits the TET2 and affects the DNA methylation. And then it has progressed with other diseases also. They have seen as chondrosarcomas, cholangiocarcinoma. This all the different diseases, this mutation has been commonly identified. The interesting thing, after 2013-14, the target inhibitors have been come for the IDH1, which were in the pipeline, which we'll discuss in the subsequent slides. The next slide. Basically, as we have discussed here, in the IDH2 mutation, AML, we can see around 15 to 20%. And IDH1 also we can see, but that is around 8 to 10%. Rest of the diseases in the MDS, angioimmunoblastic non-Hodgkin lymphoma, intrahepatic cholangiocarcinoma, many of the other diseases where we can see this IDH1 and 2 mutation. What exactly it works? Basically in the IDH, next slide. The IDH expressed in the cytoplasm, and one is expressed in the cytoplasm and the 2 is expressed in the mitochondria. In the another slide, next slide please. Yeah, so here we can see here, basically IDH1, it is in the cytoplasm where isocitrate and gets converted into alpha ketoglutarate with the help of IDH1. Wherever there is a mutation in the IDH1, it gets formation of the oncometabolite, that is 2-hydroxyglutarate. And the mitochondria where we see IDH2, IDH3, where again the same procedure it leads to the mutation formation of the 2-hydroxyglutarate. So here basically it is a causing epigenetic deregulation in the nucleus in the next slide. And what we have seen as a deregulation of the epigenetics and the histone demethylation. So these are the two basic mechanism in the pathogenesis in the AML where this IDH mutation can lead. Basically, we are more aware of the SEPA, NPM and FLT3, even in the ELM classification about these three only we have mentioned morely. But now the IDH is coming in last couple of years. Wherever there is a normal karyotype, cytogenetic is normal. And most of the time IDH is associated. We can see in the next slide, this is the Asian Pacific Journal of the Cancer Prevention. Next slide, please. Yeah, in this was an Indian journal where they have mentioned about the back slides. This was the Indian study. Basically, they have come to the came 2014-15, they concluded that DNMT3 and IDH genes were commonly associated with the FLT3 and NPN, and they were found around 15 to 20% of the patients, with more commonly seen in the adult patient, not in the pediatric. And basically, the outcomes were depend on the whether FLT3 was associated with or not, NPM was associated with or not. So on this basis, the two drugs have been come. We are going to discuss that on the next slide. That is your IDH2 inhibitors. That is your inacitinib. That is an allosteric inhibitor of the mutated IDH2. Here, as we have seen in the previous slide, that inhibits the formation of the 2-hydroxyglutarate, and that leads to decrease in the oncometabolite. This was a study what they have done on this, and this was the next slide where the inacitinib in the relapse refractory cases where the mutation was present in that the phase 1, phase 2 trial. Initially, they have begun with the doses of the 50 to 650, then progressed to 100. Then they have given continuous for the 28-day cycles. And this was initially recommended for the relapse refractory AMLs in the older age group above 60. Basically, they have used. And in the next slide, they have seen the safeties. What are the issues more commonly? They were seen with the hyperbilirubinemia. Hepatitis were more common, associated with nausea, decreased appetite, vomiting, diarrhea, and more importantly, like our PML RARA, they used to see commonly differentiation syndrome was also observed with these inhibitors. Next slide. After giving this, the median overall survival, what they have noticed in the beginning was around 9 months. For that, when they have started the treatment for the 1 month overall survival, and the overall best response what they have seen with the CR was above 55, around 50-55% was there, less compared to the other. But what this was looks like promising in the beginning, what we have seen. Then the another drug they have worked out on was ivosidenib. That was IDH1 inhibitor. Next slide. In the next slide. So ivosidenib was IDH1 mutated. Initially in the beginning, again it was trialed for the relapse refractory AML cases, not in the upfront cases in the beginning. Then again the same results what we have seen in the CR, where around 50% response was there in the beginning, what we have seen in this from this study. The next slide. Again, here the side effect adverse events was what they have seen more than grade 3. That was leukocytosis in the beginning, which they used to control with the hydroxyurea. Then QT prolongation was commonly seen, that was monitored. There was IDH differentiation syndrome that was again managed with the corticosteroid. Next slide. In this study, in the beginning, again, the doses were very haphazardly used in the mutated cases for the 100 mg BID, then 300 mg. And finally, they have concluded dose expansion of 500 mg per day orally for 28-day cycle. So according to this, the adverse events are monitored. The next slide. The baseline characteristics, as we have already told, that the age group was above 60s in the relapse refractory, and the upfront of the cases also they have tried. Untreated cases was around 75 who are not able to go with the our routine inductions with the ECOG performance was low. Then few cases were also tried with the hypomethylating agents like azacitidine with ivosidenib. In that also, the next slide. In untreated cases, the complete remission, the response rate were around 40 to 45%, with the median time to CR was around 3 months. Then they have continued. This was a trial in the beginning. What they have used, this was published in the ASH abstract in the 2018. The next slide, please. The ivosidenib. In the untreated, again, mutation, the duration of treatment and best overall response over the 6 months and the 12 months, what they have seen in the CR plus was around 90%, but the overall response was 77% at the 6 months, and 12 months was around 60% overall response. The median overall survival period was around 12.5 months after the this therapy for the IDH1 mutated in the untreated cases, what we have discussed. So this was another study design, the next slide, where patients with the newly diagnosed de novo or secondary AML and located documented as IDH1 and or IDH2 mutation, no previous chemotherapy for the AML. Then they have seen this was a trial for the IDH1 mutation and IDH2, and IDH1 ivosidenib 500 with cytarabine plus daunorubicin. This was above 18 years, and then they have seen followed or daunorubicin or idarubicin. Then we have seen for the after induction 1 to 2 cycle, then whether it was CR or incomplete remission. Then they have gone for consolidation, and then finally went with only the drug at least for the 2 years what they have enrolled. This study is yet to be get published outcomes for this. And for the IDH2 mutation inhibitors for inalidacinib, they have used again the same protocol with the cytarabine, daunorubicin or idarubicin, and consolidation was done with the cytarabine or mitoxantrone etoposide and followed by drug oral for 2 years. The secondary exploratory endpoints, the clinical activity, MRD status by flow cytometry, IDS mutation, and clearance by digital PCR was in process. The next slide.
So, sir, requesting you to conclude, sir. We are running short of time, sir.
Yeah. Sir. This is my another last slide now. Next slide, please. This was another next slide. Yeah, characteristic, clinical outcome, and prognostication significance of IDH mutations in AML. They have seen the pathophysiology of IDH mutation was described, and the prognostication was controversial. They have studied around 826 patients, out of which including 20% with AML, IDH and IDH2 mutations. Median age was 62 years. This was in that they have divided the mutations for the IDH1, 2, and the remission rates, what we have discussed, around 68% was in the induction. Salvage 1 was 42% and salvage 2 was 27%. The overall median survival was 15.4 months. This was a study published in the American Journal of Hematology. So mutations, we have to decide whether newer therapies, we have to take a call depending on the ECOG performance, age, and the mutation targeted. To conclude, IDH1 and 2 inhibitors are well tolerated in this patient population. Most adverse events, next slide. Next slide. Yeah, to conclude, IDH1, 2 inhibitors are well tolerated in this patient population. Most adverse events were not treatment related and went grade 1 to 2 in severity. In patient with relapse refractory AMLs, IDH1, 2 inhibitors induced durable CRs and were associated with overall survival more than 8 months. Response to the inhibitors where with the several treatment cycles were seen. Differentiation appears to drive the clinical efficacy. Ongoing studies are there for the phase 3 and phase 4 trial. Next slide. The treatment option of AML has never been so varied and so bright. With these new options have come increased complexity. Targeted therapy of patients with the AML and IDH mutations are now approved in both the newly diagnosed and the relapse refractory setting. Thank you. Next slide.
Thank you so much, Varun sir. So we'll now move on to our panel discussion. We have our moderator is none other than Dr. Hemant Malhotra, who's a senior medical oncologist and hemato-oncologist from Jaipur. His panelists are Dr. Srinivas Rawat, medical oncologist from Pune, Dr. Dipanjan Haldar, hematologist from Mumbai, Dr. Anand Gokaran, hemato-oncologist from Mumbai, and Dr. Venkatesh Ikbute, hematologist from Aurangabad. Hemant sir, please note Dr. Joseph and Dr. Sanyal will not be able to join us. Over to you, sir.
Thank you, Kashish. Real pleasure and privilege to be here, and most cordial welcome to my very, very learned panel. Many thanks to the organizers of this meeting, Dr. Randeep and Dr. Manoj, for a beautifully organized meeting. Very, properly selected patient topics and great speakers. So AML, as you know, is like a separate. Can you hear me? Am I audible?
Yes, sir, you're audible, sir.
Yes, sir. I can hear some audio disturbance. What's going on?
Sir Srinivas, sir, have you logged in with two devices by any chance?
Should I carry on?
Let me stop.
Should I carry on?
Srinivas, sir, can I? Yes, sir, please go on.
Yeah, okay. So you know that acute myeloid leukemia is a huge topic and it is worthy of conferences, standalone conferences in itself. And we've had a wonderful talk by Varun just now on IDH mutations. So we will do a panel discussion of our experts and see if we can bring out some of the important practical issues in managing this very tough disease to manage. So thanks very much for this opportunity. And here is the list of the panelists which I got. Really sad that Dr. Joseph John and Dr. Sanyal is not with us, but we will more than make up with the experts which we have. So, as already spoken in the previous session, AML treatment is evolving and several new questions are being raised and answered every week, every month. And the most important one, of course, is how can we best use available therapies across treatments? How do we stratify our patients? How do we choose an induction regime? What do we do post-induction? Who should receive post-remission maintenance? And what is the status of transplant today? So we can't answer all these questions today, but some of these we will try to address. Now, the most important thing is if you get a patient tomorrow on Monday morning, what considerations would you choose in selecting the first-line treatment? And we know that historically, age has been a key factor in selecting initial treatment. Patients who are younger and fitter, we opt to give them intensive induction. And patients who are older and frail, we think of low-intensity treatment. But just chronological age is not the deciding factor. There are several other things which we take into consideration, and most important being fitness and the comorbidities which the patient has. And this is a cartoon to depict some of those. For somebody who is frail, whatever the age might be, we think of non-intensive treatments. Someone who is, and possibly only best supportive treatment also, and somebody who is a little better, performance status is better, less or no comorbidities, we think of less intensive treatments. And for somebody who is young and fit, who's able to climb this mountain, we think of intensive treatments. And our goal for at least this group and this group is to get the patient into CR and then to think of post-remission treatments. So let me start with a case. So we have a 73-year-old male with a 4-year history of low-risk myelodysplastic syndrome, not requiring treatment other than intermittent transfusion. He has trisomy 8, DNMT3A, and SRSF2 mutations. He also has coronary artery disease for which he had been stented about 2 years back. He's now come with progressive cytopenias and he's now symptomatic. Marrow reveals 25% blasts. Flow is consistent with acute myeloid leukemia. And this patient himself, as well as the family, wants to focus on quality of life as a priority. So this is the question to my panelists, and I'll start with Dr. Srinivas. Dr. Srinivas, are you there? How would you treat this patient? Dr. Srinivas, can you please unmute yourself and address this question?
Yes. Patient is 73 years old and he's frail to tolerate intensive remission induction therapy. So if it is so, then we have to see whether the patient is with or without actionable mutations with FLT3D ITD, FLT3 ITD mutations with IDH1 or IDH2 mutations, and we have to give the concerned options of either benefit based therapies or demethylating based therapies or targeted therapies.
Okay, very good.
Okay, very good.
So can I ask the same question to Anand? Anand, what do you do in addition to what Dr. Srinivas has told us?
So I would agree with Dr. Srinivas, and the intent would be palliative and to maintain the quality of life. It would be intensive chemotherapy is out of the table, and I would also go with hypomethylating agents and maybe continue supportive care, transfusions to just keep the patient in a good state.
Correct, very good. So I think this is the list of the options available to us today for patients who are ineligible for intensive treatment. And can I ask Dr. Dipanjan, if all these medicines were available to you, and out of all these options, considering our patient, what would you choose? Would you choose only a hypomethylating agent, or would you choose the BCL6 inhibitor along with the hypomethylating agents? Or would you choose low dose hypomethylating agent alone or one of the other agents? Dr. Dipanjan?
Yeah, hi. Good afternoon, sir. So I would clearly go for azacitidine and venetoclax combination. The reason being the data published in the ASH 2019 is quite strong and goes in favor of venetoclax azacitidine. This is a regimen which is quite well tolerated, has shown significant difference in progression-free survival as well as overall survival in comparison to azacitidine alone. So I definitely go with the combination of azacitidine and venetoclax.
So Dr. Venkatesh, any difference of opinion, or would you choose the same regimen?
Yes, quite an interesting question. Yes, my first preference would still be azacitidine venetoclax. But one regimen which is missing in this entire schema is azacitidine plus lenalidomide. So what I would suggest is, because the patient has DNMT3A mutation and the fact that venetoclax can cause prolonged cytopenia in these individuals, which will interfere with quality of life, and SF3B mutation is also sensitive to lenalidomide, and it is used in patients who have MDS. So in a patient with secondary AML with 2 mutations, both of which can be sensitive to hypomethylating agents and lenalidomide, I would try to, if less is more is our philosophy, then I would go ahead and start him on azacitidine lenalidomide. And only if he doesn't achieve remission with that, I would offer him venetoclax. That way I can cut down the initial cytopenia, which can be really prolonged in these individuals.
I think that's a very valid point which Dr. Venkatesh has brought out. And, for us, most of us, we have difficulty in procuring the venetoclax. So a combination of len with a hypomethylating agent might be a good combination. Again, cytopenia will be a problem, but I guess when you're treating AMLs, you have to kind of accept that. And, this was the trial which was being mentioned by my panelists, the Way trial, randomized patients ineligible for intensive induction, advanced age with comorbidities, randomized to venetoclax AZA plus AZA alone, and a very significant difference in overall survival, hazard ratio of 0.66 and a p-value of 0.001. And as has been pointed out by the panelists, this is probably one of the regimes of choice for the patient population who is ineligible for induction treatment. Not only does it produce a significant difference in overall survival, but the incidence of MRD negativity also is significantly better if you combine venetoclax and AZA. And of course, toxicity is there, not without toxicity. Almost half of the patients have neutropenia, almost half have febrile neutropenia. But I guess that is part and parcel of AML treatment, whatever you do. So now another question to the panel, and I'd like to start with Anant this time. Anant, what mutations at diagnosis impact the addition of venetoclax to hypomethylating agents Is there a predictive marker where you would give only hypomethylating agents, or you would give the combination? Anand, please.
I'm not sure, but I think DNMT3A mutations would help us in using these therapies. But I'm not really sure which is there a predictive marker that would help us guide using venetoclax over hypomethylating agent.
Anybody else wants to take this?
Yes, I can take this.
Yeah, please go
I'll
ahead.
go first. Yeah, I think one is, of course, a complex karyotype, which helps us in deciding that whether azacitidine or single agent azacitidine itself will help us. Then the second option is more than 3 mutations on NGS panel. And the third is if any one of these mutations is a TP53 or a 17p deletion or a monosomal karyotype. In these circumstances, azacitidine alone will or decitabine alone will not be very useful. And in these circumstances, because we are dealing with multiple clones, venetoclax is the best option. And it has been tested that the impact of TP53 is abrogated by addition of venetoclax to hypomethylating agents in these circumstances.
Very true. So if the patient has any adverse cytogenetics or secondary AML or high-risk mutations like the TP53, then the combination is probably better than the single-agent hypomethylating. Let's come to another case like a shift in spectrum. Now we have a young 35-year-old fit patient, usual symptoms of progressive anemia, very low hemoglobin, slightly high counts, significant blasts in the peripheral blood. Flow is suggestive of classical AML with monocytoid differentiation, and patient has sepsis requiring ICU admissions and supportive care and antibiotics. AML multiplex panel detects the 821 mutation. Marrow shows lots of blasts, and marrow also shows multi-lineage dysplasia, and genetic abnormality 821 is confirmed. So this is the fish panel for the patient. 821 has been detected in this patient, and he's young and he's fit and is now, after his short ICU stint with antibiotics and supportive care, recovered and fit for treatment. Now, how would you treat this patient? Let me ask Dr. Venkatesh this. Dr. Venkatesh, what would be your approach to treating this patient?
Right. So, in this 35-year-old gentleman with a translocation 821 AML without any molecular abnormalities, including the c-KIT, my first preference would be a standard 7+3 induction regimen. Although, and in spite of the fact that there is multilineage dysplasia on the marrow, because multilineage dysplasia can appear in patients morphologically in patients who have 821, but in spite of that fact, the cytogenetic abnormality is actually the main marker which is used to stratify these individuals into a good risk category. So first choice 7+3. Although there is a wonderful paper coming out of the CalGB group, which now propose that dasatinib can be added to 7+3 regimen to improve outcome in these patients, irrespective of the fact that they may not have a c-KIT mutation. So even in patients who are c-KIT negative, you may be able to offer dasatinib, but I would still wait for more data along those lines because it's still a single center study.
Thank you very much. Dr. Dipanjan, would you agree or would you do something different?
Yeah, I think I'll agree with this. So I definitely go ahead with standard 7+3 induction regimen. And so post-remission, so only thing is like post-remission, I would also go ahead with the assessment of AML MRD. So because it has been shown to significantly impact the outcome even in the favorable risk groups. So that is what I will do in addition.
Right. So for the patient who is young and fit and eligible for aggressive treatment, the standard still remains are 7+3 or 3+7, whatever you call it. And if there is 3 mutation, you add midostaurin. If the patient has therapy-related AML, then you could consider CPX351. if the patient has CD33 positivity and core binding factor positive AML, and you might think of adding the anti-CD33 monoclonal antibody, the GO as it is called in short. And again, standard induction therapy is to be given to young patients, and depending upon what molecular abnormality they have, what target gene abnormality they have, you can add for the FLT3 midostaurin, and for the core binding factor abnormalities, you may think of gemtuzumab. Gemtuzumab, you know, has been up and down, available, not available, but now it does seem to have some benefit in patients, particularly who are good risk and intermediate risk cytogenetics and who have the core binding factor. And FLT3 inhibitors, you know, midostaurin is approved and available in our country, and there are several others in trial, and hopefully will be available to us, and we will have a choice in these. So now this is my next question to my panel. Let me start with Anant now. Anant, in your opinion, should MRD assessment become standard of care in AML? And if your answer is yes, when would you like to do the MRD?
MRD assessment should be the standard of care. I am assuming that there are resource constraint settings, but assuming that there are no resource constraints, then we should do MRD for each patient, because it helps us predict the subset of patients who can have a relapse, and especially if there is data in using molecular targets of NPM1, those who have persistent NPM1 positivity after the first consolidation, the second chemotherapy, the relapse rates are as high as 80% as compared to 30% those who have negative MRD. So MRD assessment does help us select a subset of group who will do extremely poorly, and we may consider escalation and giving better consolidations like transplants to these patients. So MRD should be offered, assessment should be offered to all AML patients.
And Dr. Srinivas, do you agree with that?
Yes. MRD is, I think, standard of care in all leukemias at least. MRD helps us to select the post-induction therapy, even whether there is significant residual disease without hypocellular bone marrow. So bone marrow is also important, whether because and duration of recovery of the cells. It also matters, because many times we do bone marrow at 14 to 21 days, but there is no marrow recovery. Then we again have to do at 28 days or after marrow recovery. Then the things complicate, and they help us to decide the post-induction therapies.
So ideally speaking, which is the optimal time to do an MRD in a patient of AML or induction treatment?
Bone marrow aspiration and biopsy, they recommend at 14 to 21 days. But MRD, we send at the same time we do bone marrow. And if it is bone marrow is repeated, then we have to again repeat.
Very good, thank you. Any other inputs from my other panelists regarding MRD in AML? So this is the NCCN guidelines for minimal residual disease assessment in AML. It can be done by PCR, or also be done by multicolor flow, and it does predict for molecular relapse. If after induction your patient is significantly MRD positive, then you may think of escalating the treatment in the form that you may think of a transplant sooner rather than later. So these are some of the points in the NCCN guidelines. So now this is my last question to the panel, and I want each one of my panels to address this. We will start with Dr. Srinivas. in your opinion, which single advance has impacted on AML treatment the most in the past 10 years? Dr. Srinivas?
Targeted therapies.
Very good. Very brief answer and very targeted answer. Dr. Dipanjan?
So for the young patients, definitely FLT3 inhibitors. For elderly patients, addition of venetoclax.
Great. Dr. Anant, in your opinion, which is the single most important advance in AML treatment?
I think one is availability of targeted drug like midostaurin, and second in India is availability of more bone marrow transplant centers. I mean, especially in high risk and even in intermediate risk subgroups. In India, a decade back, there were hardly 3 or 4 centers which are doing it, but now many private institutes are also doing bone marrow transplant. I think for AML, that is the single most important thing that has come up, because I mean, most of the patients would not have a targetable mutation, and for them BMT would be the only kind of curative option.
Very good. I think that's a very important point. Dr. Venkatesh, your answer to this question?
I totally agree with Dr. Anand over here. And for me, the single most important impactful advance has been, successful haploidentical transplant. I think because they are in the algorithm, one strives to achieve MRD negativity thanks to wonderful targeted therapeutic drugs, including venetoclax. And in fact, we have also been able to exploit that in India by reducing the dose of venetoclax, thereby combining it with posaconazole, thereby reducing the cost to the patient, and eventually taking these patients for a haploidentical transplant after they become MRD negative. So if there was no haploidentical transplant, I would, not be trying to achieve MRD negative status in these patients. So I think that one single treatment option has made a lot of difference.
Excellent. So this is my kind of stay-at-home message. AML treatment landscape is evolving quickly. All patients of AML, of course, who can afford targeted treatment, we must look for the target and the panel which you must apply for all or most patients of AML is pretty much standardized now. There are several approaches which have shown a survival improvement, and I think one of the most exciting approaches is the combination of venetoclax azacitidine, particularly for patients who are poor risk, who are old, which is the majority, and who have several comorbidities, which again is very common in these elderly patients. And so AML is being increasingly treated in an outpatient setting, and you call the patient in as and when there is a complication. This again is a big advantage for the patient. Also prevents hospital-acquired infection in the patient. And of course, as all my panelists pointed out, recent advances in targeted therapies are providing options for patients with specific mutations. And several of these targeted therapies are now fortunately available in our country, and more are being developed. Of course, they are very expensive options because alternative generics are not important. But if you just talk about the science, then the science is there, and these targeted therapies are majorly impacting on the prognosis which our patients have. We are able to treat now more and more patients who were earlier just offered 3-7 remission rates of 40 to 50%, 3-year progression-free survival rates of 10 to 20%. And ongoing trials are continuing to evaluate new approaches. And I mean, I have no hesitation in saying that the AMLs which we were treating 30 years back when I started oncology is completely different from the AML now. We have several other options of treatment, and the outcomes which were uniformly bad at that time. Uniformly bad means that patients used to spend months and months of treatment and lakhs of rupees on treatment, and only 1 out of 10 patients would continue to be in remission after 3 years. So that is changing because of the availability of our precise treatments and our good treatments. And with that, I think this is my last slide. I'd like to conclude, and I'm happy to convey to the organizers that we've gained a few minutes for that. So I'm back to the Kashish and team to take over. And
thank you so
very,
much, sir.
very much for my panelists. They've done a really wonderful job. Thank you very much.
Thank you so much, sir. If you have any questions for Hemant sir and the panelists, we can keep it open for the next 30 seconds. You can also raise your hand or put the questions in the chat box.
Any questions or comments either from the panelists or any question, comments, whatever you want to say? The organizers are giving us a few more minutes, which is kind of rare.
I think there's one question which has popped up in the chat box. I think it's about thrombosis in acute myeloid leukemia, still awaiting treatment. Yeah, so that's a very sticky question, very specific.
Okay,
yes.
Which one of my panelists want to take this? The patient diagnosed with acute myeloid leukemia has deep vein thrombosis. Would you treat or would you not treat? How would you treat? The presence of thrombosis, would that impact the therapy? Anand, you want to take this?
Yeah, so this is a very tricky and difficult situation. I mean, if the platelet count is more than 50,000, I would go ahead with the anticoagulation with the low molecular weight heparin. But if it is less than 50,000, it becomes difficult to use it because of the additional risk of bleeding. So, I mean, so if the main thing would be to treat the underlying malignancy and use anticoagulation, keeping the platelet count more than 50,000. That is what I would suggest.
Banjan, any input from your side?
I think I would completely agree. So we recently had a similar situation where a patient of aplastic anemia developed pulmonary embolism and secondary to COVID infection. So we were in a similar situation, and so because clear pulmonary embolism, patient was on ventilator. So this is the most practical thing to do. I mean, give the patient anticoagulation as well as keep the platelets more than 50,000 by monitoring twice daily platelet counts.
Yeah, so don't be miserly with your anticoagulation treatment, your low molecular weight heparin, then maybe your DOACs, but be more aggressive with your platelet transfusions. Dr. Srinivas, you have a comment on this?
Actually, where is the thrombosis? Site of thrombosis also matters, because there are some recent studies regarding Xarelto, GI and GU, excepting GI, GU site, you can prefer newer oral anticoagulants. So site of thrombosis also matters, I think.
Agreed. Okay, Kashish, I think we are done. Back to you for the next session. And thank you very much again, my panelists, for very, very good interactions. And I hope the audience, I can see 42 people, participants, they gained something from this panel discussion. Thank you very much.
Thank you so much, sir. And thank you to all the panelists. We'll now move on to our next session. Our next session is sponsored by Novartis. Our speaker is Dr. Vishnu Sharma, who is a hematologist. He's a hematologist from Jaipur. He'll be talking on the topic, optimize CML management in new decade. Without wasting any further, I would now request Vishnu sir to please share his screen. Over to you, sir.
Thank you so much for a kind introduction. So I'll be speaking on CML management in this decade. So I'm sharing my slides. So my slides are visible?
Sir, yes, sir, it's visible now. So you can make it full screen, sir. Perfect, sir. Thank you, sir.
So topic allotted to me is optimize CML management in new decade. So as we all know, CML is a disorder of pluripotent stem cells because of balanced translocation of 922, leading to formation of chimeric oncogenic protein BCR-EDL, and which leads to uncontrolled proliferation of mature myeloid cells. So previously, before the TKI era, CML was considered as a progressive disease, and bone marrow transplantation was the only cure. And overall survival was around 3 to 5 years. So with the inception of this tyrosine kinase inhibitor, first with imatinib, the survival has improved from this 3 to 5 years to almost comparable to normal age-matched healthy population. So these results have been obtained in many cases, not only by imatinib, but also by the other tyrosine kinase inhibitors. So we have several options for treatment of CML CP, but still first line option is imatinib, considering the better tolerability, lesser side effect profile, and still cheaper compared to the other second generation TKI. Second line options includes second generation TKI like nilotinib, dasatinib, bosutinib, and ponatinib in cases of T315I mutations. And third line mutations, third line options for patients who develop like tyrosine kinase domain mutations, or who are intolerant to other second generation TKIs, includes other second generation TKI like bosutinib, ponatinib, dasatinib, or in selected subgroup of patients, stem cell transplantation is the option. Patients who fail to all three lines, or who are intolerant, or who had progressive disease, can be enrolled in clinical trials or can be subjected to stem cell transplantation. So prompt tyrosine kinase treatment is the option, and this is the IRIS study which based on which imatinib was approved for treatment of CML-CP. This almost 50% patient enrolled into imatinib arm, and almost 50% patient enrolled into interferon alpha plus cytarabine, and this crossover was allowed. So 10-year overall survival was 83.3% in patients who are on imatinib, compared to 78.8% in patients who are on interferon alpha plus cytarabine, though there was extensive crossover was there. So in the German CML study, almost 1,500 patients were enrolled into 5 groups: imatinib 400 milligram, imatinib plus interferon, imatinib plus cytarabine, imatinib after interferon, or imatinib 800 milligram. So overall survival remains same in all the groups. Around 80% in patients with imatinib 400 milligram, 84% in patients with imatinib plus interferon and imatinib plus cytarabine, and around 80% in patients with imatinib 800 milligram and imatinib after interferon alpha. So this shows that imatinib 400 milligram is still a standard of care in patients with CML-CP. When we talk about the cause of death in patients with CML, most of the patients who died because of patient of CML died are unrelated to CML. So almost 2/3 patients who died was because of causes unrelated to CML, and 1/3 patient died because of directly related to CML. So 6% patients died because of causes related to CML, and 12% patient died because of causes unrelated to CML. So when we talk about the disease progression, so most of the patients progressed in the first 1-2 years of the post TKI treatment, and progression after 2-3 years is uncommon, but still progression is a major cause of CML related death. So when we talk about the major molecular responses, it has been shown and it has been demonstrated in various studies that patients who attain major molecular response at 12-month time point and 18-month time point do better. So patients who developed in IRIS study, this was compared in patients who developed major molecular response at 12 months and patients who did not develop major molecular response at 12 months. So overall survival was better, though it was not statistically significant at 12-month time point. But estimated 10-year freedom from CML related death was significantly better in patients who attain major molecular response at 12-month time point. It was 97.8% in patients who attain major molecular response or better, and 89.4% in patients who did not attain major molecular response. And this effect was more evident at 18-month time point. So estimated 10-year overall survival and freedom from CML related death both were found to be better in patients who attain major molecular response. So achievement of MMR is necessary, and it avoids the risk of CML-related death and chances of disease progression. So both depths of response and speed of response are important, and it has been shown in various trials that patients who attain early response will also likely to develop deeper responses. So these early response is independent predictor of long-term survival. This diagram showing that DCR-ABL percentage or molecular responses is directly proportional to the number of leukemic cells or number of leukemic cellular burden. So as the molecular responses deepens, the number of leukemic cells also goes down. Similarly with cytogenetics, but it is limited up to major molecular response. So early molecular response again is a surrogate marker of outcomes. So in this study, they showed that patients who were on nilotinib 300 milligram and on imatinib 400 milligram at 3 months, the predictive of future overall survival. Patients who attain molecular response less than 10% at 3 months in both the groups showed better overall survival compared to patients who failed to attain response less than 10%. So monitoring of BCR-ABL is very, very important, and it is failing to monitor the response is like driving into the night with light off. So it may be very, very dangerous. Monitoring frequency as recommended by various guidelines is 2 to 4 times in a year. Ideally, every patient should be monitored every 3 monthly, and it has been shown to reduce the risk of progression and increase the adherence to treatment. So molecular monitoring must be appropriate, and it is essential to have a molecular data reliable. Each step of the analytical process should be standardized, and the report of the result should be according to the international scale. So there are new changes which are incorporated into the 2020 ELN recommendations, especially if patient has failed to attain early molecular response at 3 months, that is BCR-ABL more than 10%, and if confirmed within 1 to 3 months is considered as TKI failure, and patient should be evaluated for tyrosine kinase domain mutation, and this compliance should also be reconfirmed. And another change is BCR-ABL more than 0.1% or 1% with loss of MMR is also considered as warning. So when we talk about the intolerance to the imatinib, almost 55% patients continued on frontline imatinib, while 45% patients discontinued imatinib because of various reasons, which includes adverse events, unsatisfactory therapeutic effect, death, or some patients underwent stem cell transplantation and some other unidentified causes. So patients who switched from imatinib to other TKI will also have a better response. Like 57% patients had a improved overall response rate compared to patients who are continuing on imatinib. So when to switch and how to switch, it is very, very important. Progression-free survival, this curve is showing that patients who attain early molecular response, that is molecular response less than 10% at 3 months time point, or patients who attain less than 1% BCR-ABL at 3 months time point, and patients who had more than 10% BCR-ABL at 3 points. So red curve is showing BCR-ABL less than 1% at 3 months. Blue is showing 1 to 10%, and yellow is showing more than 10%. So patients who had less than 1% BCR-ABL at 3 months had a better progression-free survival. That was 85% patients, 85% in less than 1%, 67% in 1 to 10%, and 42% in patients with more than 10%. Similarly, at 6 months also, patients who had BCR-ABL less than 1% at 6 months had a better progression-free survival, that was 86% in less than 1% arm, 58% in 1 to 10% arm, and more than 10% arm had 39% progression-free survival. Similarly, at 12 months, patients who attain complete cytogenetic response has a better progression-free survival compared to patients who fail to attain complete cytogenetic response. So it was 89% patients had progression-free survival in complete cytogenetic response arm compared to 56%. So higher rates of MR 4.5 was achieved with switch to nilotinib versus continuing imatinib treatment. So patients who continued on imatinib at 12 months time point had 13.5% response rate compared to 32.7% in nilotinib 400 milligram arm. And by 24 months, it was 42.9% in nilotinib 400 milligram BD compared to 20.8% in imatinib arm. Similarly, better response was observed at 36 months and 48 months time point also. So which result can we expect with second generation TKI in patients who had imatinib failure? So there was no comparison, head-to-head comparison between second generation TKI. Data are available from different studies, but there was no direct comparison. So almost all three second generation TKI which are available in India are comparable in all aspects. More than 24 months follow-up is available for dasatinib and nilotinib, and bosutinib also. So complete hematological response, almost 85-86% patients with bosutinib, 89% patients with dasatinib, and 77% patients with nilotinib attain complete hematological response. Major cytogenetic response was also comparable. Complete cytogenetic response was around 44-40% in all three TKIs. So 24 months overall survival was also comparable. So in terms of response, all three TKIs are comparable. So why not simply increasing imatinib doses? Because imatinib, increasing in imatinib dose has a poor tolerance and inferior and transient results. So it is better to switch to second generation TKI compared to continuing on imatinib and increasing the dose of imatinib. And higher and better response are expected in patients who switch to second generation TKI. So how to select second generation TKI for patients who are either imatinib intolerant or imatinib resistant? So patients who develop imatinib intolerance or resistant, tyrosine kinase, second generation tyrosine kinase inhibitor should be selected based upon the TKD mutations. Certain mutations are sensitive to like bosutinib, or certain mutations are sensitive to dasatinib or nilotinib. So based on sensitivity pattern, second generation TKI should be selected. And there are certain side effects which are associated with second generation TKI. These side effects should also be considered while choosing for second generation TKI. Like pleural effusion is more common in patients with dasatinib. Transaminitis and this transaminitis elevation is more common in patients with bosutinib. Diarrhea is more common with bosutinib. Cardiovascular events and metabolic derangements are more common with nilotinib. And dasatinib is associated with pericardial pleural effusion like that. So it has been observed that patients who are on any tyrosine kinase inhibitor has a higher incidences of developing cardiovascular events. So all TKI are associated with higher cardiovascular events when we compare to the general population. So arterial thrombotic events, when we talk about the arterial thrombotic events, CML CP patients versus general population, this shows that CML CP patients on any TKI had a higher incidences of arterial thrombotic events. When we compare nilotinib versus with imatinib, nilotinib has a higher chances of developing arterial thrombotic events, and same with dasatinib. Myocardial infarctions are also more common compared with a general population, and it is higher with nilotinib compared with the imatinib. So patients who had a baseline risk for developing cardiovascular events like smokers, hypercholesterolemia, or diabetes, hypertension, also has a higher risk of developing cardiovascular events with any TKI like imatinib or nilotinib. So how what can we expect according to the current data? So in the Indian setting, imatinib is still first-line therapy, considering low cost, better side effect profile, and tolerability. So almost 60% patients achieve durable response with imatinib, and 40% patients out of these 40% patients were eligible for trial of treatment withdrawal, and up to 15% patients achieve operational cure. And remaining 40% patients who failed on imatinib or who developed intolerance to imatinib, they require second generation tyrosine kinase inhibitor, and almost 50% patients achieve durable response, and 50% patients require third generation TKI, and out of these 50% patients achieve durable response, and remaining 50% patients requires alternative treatment, including hematopoietic stem cell transplantation. So is this the correct sequence? Why not to start with a more potent TKI to overcome resistant clones? So current and evolving goals of CML treatment to prolong the survival, prevents the disease progression, achieve established treatment milestones like complete cytogenetic response, early molecular response, and major molecular response, achieve minimal residual disease, and discontinue treatment or consider for treatment-free remission. So second generation TKIs are also approved for first-line therapy. Nilotinib, usual dose is 300 milligram twice a day, dasatinib 100 milligram once in a day, and bosutinib 400 milligram once in a day. So second generation TKI is first-line therapy versus imatinib. So what are the pros and cons? Advantages of starting second generation TKI: it reduces the number of patients failing early molecular response, less than 10, that is less than 10% BCR-ABL at 3 months. It reduces the risk of early progression and CML-related deaths, and it induces the faster and deeper molecular responses, and more patients will be eligible for TFR. But disadvantages are they do not improve overall survival. So overall survival remains same, and are associated with more long-term toxicities, and are more expensive compared to the imatinib. So cumulative incidences of MMR by 10 years. If we start compare imatinib 400 milligram, nilotinib 400 milligram twice daily, or nilotinib 300 milligram twice daily, at 5 years as well as at 10 years, nilotinib 300 milligram daily do better compared to the imatinib 400 milligram once daily, and nilotinib 300 milligram BD and 400 milligram BD are almost comparable. So cumulative incidences of MR 4.5 by 10 years are also higher in patients who are on nilotinib 300 milligram BD compared to imatinib 400 milligram once daily. It was 61% in patients with nilotinib 300 milligram twice daily, compared to 39.2% in patients with imatinib 400 milligram once daily at 10 years, and 53.5% in nilotinib 300 milligram twice daily at 5 years, compared to 31.4% in imatinib 400 milligram once daily. So from year 5 to year 10, additional patients achieved a deeper molecular response, with more patients initiated on nilotinib continuing to meet this milestone. When we talk about the progression of disease, nilotinib significantly reduces the risk of progression at 5 years compared to imatinib. And there were no new progression to AP or BC on core treatment since the 5 years analysis. There was one additional progression to AP-BC on study, that is core plus extension in each of the nilotinib arm, and 5 additional progressions in the imatinib arm since the 5-year analysis. So estimated 5-year progression-free survival in patients with imatinib is 91.1% compared to 92% in nilotinib, 300 milligram, 95.3% in nilotinib, 400 milligram arms, and estimated 5-year overall survival is almost comparable in patients with imatinib, nilotinib, 300 and 400. So why it is so important to achieve a deeper molecular response? To attempt therapy discontinuation, patients who attain deeper molecular response, like more than MR4 or 4.5, can be considered for treatment-free remission. So this treatment-free remission was evaluated in STIM1 trial. The patient survival without molecular recurrence was observed in almost 40% of patients, and patients who most of the relapses are seen within the first 6 months. Almost 80% patients who relapse are relapsed within the first 6 months of therapy. So patient requires close follow-up and regular monitoring, especially in the first year after discontinuation of treatment. So this is basically a small percentage of the CML population. So to conclude, overall survival of CML patient is almost comparable to normal population. Imatinib 400 milligram once daily is still the most commonly used tyrosine kinase inhibitor, considering the low cost and better tolerability. Second generation TKI can be used in selected group of patients, like patients who had high SOCAL score or ELTS score, or patients who are aiming for treatment-free remission, especially young patients. And selection of second generation TKI is based on risk score, comorbidities, side effect profile, and financial conditions should also be taken into account. And selected subset of patient can be considered for treatment-free remission. So with this, I thank you all for your patient care.
Thank you so much, Vishnu sir. If you have any questions for Vishnu sir, you can, we request our participants to either put the questions in the chat box, or you could raise your hand and we can allow you to talk. If anyone has any comments, they're free to make them as well. So we'll wait for another 10 seconds before moving for the next session.
I think there is no question.
Fair enough, sir. Thank you so much, sir. Thank you for the wonderful session. We'll move on to our last session of the day as well as the conference. It gives me great pleasure to introduce our speaker. Our speaker is Dr. Aparna Dhar, who's a lead medical geneticist and genetic counselor at Core Diagnostics. So without wasting any time, over to you, ma'am.
Right, good afternoon, everyone. Thank you, organizers, for having me here today. So I've been asked to give you my thoughts on molecular profiling, genomic profiling, specifically in the realms of breast cancer. So without much further ado, I know it's the last one. We all want to go have lunch, so I'm going to keep it short and crisp, and let's get started. Next slide, please. So we already know that there are multiple clinical benefits of actually profiling your tumor. In the past, patients used to be treated as per the site of tumor. Like if it was lung cancer, you'd have a specific regimen. If it was breast cancer, you'd have a specific regimen. Now, we then understood that even within the same, if they've got different locations, such as lung, you can actually see, like in the diagram over here, these tumors can have different profiles that would in fact require different therapies. we then understood that it wasn't just simply about treating the site within the tumor or within the person, different site, different tumor, but in fact, it could be applicable in terms of treatment of multiple tumors, such as agnostic markers. Next, please. So as we move forward in precision medicine and metastatic breast cancers, I thought let's take a step back for a second and really ask the question, first of all, why is profiling even important in advanced cancers in general? And just to set the stage here, most of this lecture will be dealing with treatment and how profiling is actually used in treatment of advanced cancers. Next, please. So why profile? You know, we know identifying one important somatic mutation can make a huge difference. And I absolutely love using this example. It's one of my favorite slides. This is a case of melanoma where if given a combination of dacarbazine and chemotherapy, it would actually have approximately a 5% response rate. But upon identification of an important somatic mutation, over here it was the BRAF V600E, which is actually one of the most common mutations we see in melanomas, they treated the patient with vemurafenib, and as you can see, a picture speaks 1,000 words. There was a phenomenal response. Next, please. So is it really worthwhile finding these actionable genetic alterations in cancers in terms of long-term prognostic outcomes? And it's a very simple response, yes. As you can see here are 3 important clinical examples. Now in NSCLC, targeted therapy resulted in an overall improved survival versus those that were non-matched therapies. The same goes for even pancreatic cancer, and we know that it's a very, very hard to treat cancer, a very hard to treat tumor. Now, in the realm of breast cancer, we have very important biomarkers as ERP, we have ER, PR, and HER2/neu. Now, this is an example, this graph right at the end is an example of when HER2 was introduced and how we gave anti-HER2 therapy and how it absolutely completely altered the natural history of the particular disease. What it did, it improved the prognostic outcome by actually decreasing the risk of death by almost 50%. Next, please. We also know that there are a number of important agnostic markers such as MSI, NTRK fusions, recently added TMB, and an agnostic marker is essentially where you have one target, one drug that is applicable to all tumors. So as we know, next please. So as we know, like in the case of, the next slide please. Thank you. So as we know over here, pembrolizumab was used in the case of MMR deficient or if it was MSI high tumors. Over here is a very, very important waterfall plot because we see patients responding to drugs like larotrectinib for patients which had a TRK fusion positive tumor, which is basically your NTRK. Next, please. And as we know that the FDA approvals for TMB has also made it an agnostic marker based on the Keynote 158 trials that looked at pembrolizumab amongst a plethora of different solid tumors, where the cutoff was anything greater than 10 was used, of anything greater than 10 was used. Now, the question does come up here is that in the Keynote, if you look at the data in the Keynote 158 trials, there was practically no breast cancer patients enrolled in this trial. So then it becomes questionable for tumor mutation burden of 10 to be the agnostic marker we are looking for in patients with breast cancer, for which we know that it's not inherently as immunogenic as some of the other solid tumor cancers like your melanomas, lung cancer, endometrial cancer. So my personal view is that different cutoffs are for different solid tumors, I think needs to be implemented, but that is definitely a discussion for another day. Next, please. But with physicians and, you obviously want the information early, you want it accurately. And the reason being, for patients with metastatic disease, the progression-free survival gets shorter with each subsequent line of therapy. So really, you're decreasing the patient's, So really, it actually decreases the options for these patients, and you want to treat the patient with the best therapy early, and you'd like to switch therapy early if it's not working. But if you come to think of it, the fundamental question is, does this progressive decline continue with guided treatment? And that's something that we are looking into for future prospective clinical trials. Next, please. So now we've realized that, yes, molecular profiling is important in advanced cancers. Where does it stand in the realm of breast cancer? Next, please. So patients with breast cancer, there is a very simplistic way that they're classified, and the classification is based on their ER, PR, and HER2 status. The triple-negative breast cancer subtype, TNBC, constitutes for around 15% of our patients with treatment options of chemotherapy. The hormone receptor-positive disease constitutes for around 70% of our patients, and the hormone therapy is the mainstay of treatment. Then you have your 15%, which are the HER2 positive, where anti-HER2 therapy improves significantly the prognostic outcome in both early and the advanced setting. Next, please. But honestly, when you think about it, we've really moved beyond these intrinsic subtypes. You're not just looking at your HER2s, your luminal A's, your basal-like subtype. You're starting to expand. You're looking more at genomic drivers, where we go beyond one simple classification. We're looking at, alterations in the PIK3CA pathways. We're looking at the DNA repair genes. We're looking at resistance mechanisms in the ER signaling pathway. So very, very important. And we're looking at more growth factor receptors like FGFR1, which could potentially allow us to have more targets and to help us further better personalized treatments and strategies in patients with breast cancer. Next, please. And I think it's also more important in patients with metastatic breast cancer, where the genetic landscape is very heterogeneous. So you can see on this slide, for example, that within each of the subtypes, be it the hormone receptor positive, be it the triple negative breast cancers, you have a plethora of different somatic mutations that can occur. So let's just look at the differences between early and metastatic, and you can see at least 9 driver mutations, TP53, ESR1, AKT1, etc., were more frequently mutated in the ER-positive metastatic breast cancer cases versus the early ones. In addition to this, you can see around 18 amplicons were more frequently observed in the hormone receptor positive, HER2 negative metastatic breast cancer subtype. Again, metastatic triple negative breast cancer patients showed an increase in the frequency of somatic biallelic loss of function mutations in genes associated with homologous recombination DNA repair. And the metastatic breast cancer patients actually showed an increase in the mutational burden and clonal diversity compared to early breast cancer. Next, please. So I think then the question comes is, if you know the ER/PR HER2 status, can you really look beyond that? Beyond that, can you look for these targeted therapies? And the answer is absolutely yes. We have these different targets coming into clinical practice. We have a number of diagnostics and accompanying diagnostics that can actually help you determine mutations, let's say in the PIK3CA pathway, AKT pathway, as well as the MAP kinase pathway, MAP kinase pathway. Next, please. Now we know the poster child for building a molecular profiling treatment algorithm is really lung cancer, where we know that a number of different mutations has resulted in very complex algorithms for treatment of patients. So what happens in breast cancer? Next, please. This is how we look at breast cancer. It's a very simplistic way of looking at breast cancer, where it alludes to the fact that there are only 3 biomarkers, ER, PR, and HER2/neu. It actually leads to the assumption that these are the only biomarkers that are responsible for breast cancer. It also says that, it is like the disease stays static. But we know that patients with tumors, especially when the tumor is recur, or if it's a metastatic de novo case and it progresses, these biomarkers are not static. And in about 30% of patients, the ER/PR HER2/neu could have a loss or a gain of function. It is also assumed that there's only one pathway that dominates, which again, I'm going to show you that it's not really true. We have to look at other pathways, the other different pathways that are activated to treat our patients. Next, please. So this is a very simplistic view of patients with metastatic triple-negative breast cancer. Chemotherapy treatment options of choice, and you can see that the PFS decreases with each line of treatment. Next, please. Now let's look at the tumor biology of triple-negative breast cancer patients. We know they are typically associated with the worst prognostic outcome. As you can see from this heat map over here, that patients with triple-negative breast cancer, it's not as simple as we think it is. Even amongst this group of patients, we see subtypes like luminal AR, we see mesenchymal, basal immune suppressed, basal immune activated, and among each of these subtypes, we have different treatment strategies. For example, immunotherapy for basal immunoactivated subtype, PARP inhibitors for those with alterations in the DNA damage repair pathway. Then you have immunotherapy combinations in your basal immune suppressed subtype. And of course, you've got your anti-androgen therapy in your luminal AR. So technically, not a very simplistic view. Next, please. And let's make this a little bit more complicated. Now, in the first line setting, if you were to profile your patients with metastatic triple-negative breast cancer, you in fact could get alterations in one of these pathways. You could have a defect in the DNA damage repair pathway where PARP and platinum has a clear role. We could have an inflamed phenotype where immunotherapy plays a role. And if androgen pathway is positive, if the androgen receptor pathway, is positive, we have agents for that. We have alterations in PIK3CA pathway. Then we have the PIK3CA pathways. We have our AKT inhibitors. And last and definitely not the least, we have our agnostic markers. Next, please. So I just want to give you a very quick flavor of the different studies that I've used to help, to help put together my proposed algorithm for triple-negative breast cancer patients. I'm going to start with the Impassion 130 trials for TNBC patients, which illustrated that in the PDL positive cohort, we did see an improvement in the overall survival as depicted in these Kaplan-Meier curves. Next, please. We also know that patients with triple-negative breast cancer, if they've got a germline BRCA mutation, as we saw in the Olympiad and Embraca trials, it alluded to the fact that if you have this a mutation in this biomarker, a PARP inhibitor would be given, and you see a nice separation in the Kaplan-Meier curves favoring the group of patients who receive the PARP inhibitor. Next, please. Here's another interesting data from the phase 2 trials where triple-negative breast cancer patient received a combination of paclitaxel with capivasertib, and which is a target again for the PIK pathway and an AKT inhibitor. And what you can see is alterations in the tumor see a nice separation of the Kaplan-Meier curves favoring the patients who were getting the combination versus those tumors who did not have an alteration in the pathway. Next, please. So based on this is my proposed algorithm for the metastatic triple-negative breast cancer case based on the data shown earlier. Next, please. Now let's go on to our hormone receptor positive, HER2 negative subtype. These patients not only have ER/PR as potential biomarkers, but we also need to look at different pathways, such as those that acquire an ESR1 mutation. We know that agents such as aromatase inhibitors do not work well. We need to look at agents such as fulvestrant. Again, in the HR positive, there can be a defect in the DNA damage repair pathways where PARP inhibitors can work. And we've also looked into the AKT pathways, and of course, you've got your agnostic markers. Next, please. Now, in the realm of hormone receptor positive patients, I think it's becoming extremely, extremely important to understand the tumor biology. The reason being is that patients do acquire that endocrine resistance. And you can see this is a very nice animation over here where you see patients who are endocrine sensitive, and when they are put on endocrine therapy and they do develop these their tumors, actually start developing like very small subclones of, let's say over here, of ESR1, which constitutes for about 18% of an acquired mutation. You can have around 13% have a problem or defect in the MAP kinase pathway, around 9% have acquired mutations in the MYC pathway. And these acquired alterations, genomic alterations, eventually result in endocrine resistance. And the real question that comes is that could these evolutionary tracks actually influence the choice of subsequent therapy? And as we know, the answer is yes. This can tell you if your patient has to be put on aromatase inhibitors, or you're going to put your patient on fulvestrant, or etc. Next, please. We also know that some somatic mutations differ between early and late or metastatic breast cancers, especially in our ER-positive subtype. And one of the things that's been very interesting in the last couple of years is the identification of the development of the tumors acquiring ApoBeck signatures on high TMB in our ER-positive breast cancers. Again, a potential biomarker. Next, please. So we've seen a very nice case study, and this was presented a couple of years ago at ASCO, where the patient initially had an ER-positive breast cancer in 2001 and had received the appropriate treatment for early-stage breast cancer, and eventually there was a recurrence in 2010. And then again, you can see eventually after multiple lines of therapy, in 2015, we found an ApoBeck high signature, and then eventually she was treated with a combination of immunotherapy in the form of pembrolizumab with chemotherapy, and as you can see, the patient did respond. Next, please. We've also seen the results of the SOLAR-1 trials, which was a phase 3 clinical trial looking at patients with HR-positive, HER2-negative metastatic breast cancer amongst patients that had a PIK3CA mutation and were put on a combination of fulvestrant and alpelisib, which is a PIK3CA inhibitor. You saw a very good response. And honestly, it didn't matter if the PIK3CA was tested on a plasma ctDNA or on tissue, both were equally reliable. Next, please. And as I've said before, you can acquire a HER2 mutation. So over time, we've seen these more so in patients with hormone receptor positive breast cancer. And this is a phase 2 summit trial that took patients with HR positive HER2 mutant breast cancer and gave them a combination of niraparib and fulvestrant. And these were heavily pre-treated. And what we saw was the combination did result in a clinical benefit rate of 47% of a PFS of 5.4 months. Next, please. So again, based on all this information, this is what I propose should be the tumor profiling algorithm in the realm of HR-positive, HER2-negative patients. Next, please. Now, we know that ESMO has actually come out with a scale for the clinical actionability of molecular targets, specifically for CA breast. As you see this, the level 1, level 2 incidence tends to be in terms of looking for HER2 amplification, or what we've written ERBB2, germline BRCA1 or BRCA2 mutation, a PIK3CA, your agnostic markers, your MSI, which are your MSI and NTRK. You've got your ESR1, which are your resistance mutations. You've got your PTEN loss and your AKT1 mutation. Next. And then we again have a plethora of different targets, which has, we know, less evidence that supports it, but we still look at them as the clinical trials, as there are clinical trials investigating them, and this could be potential markers. Next, please. So after talking about all these various algorithms, about all the data, I think the best way to conclude is, what do I do when a patient gets referred to my cancer genetics clinic? Next, please. In an ideal world, we would all like to send it in for tumor profiling, but I do know cost is a restriction. Cost is a constraint. Drugs can be expensive. So in the case like this, in the case of a metastatic breast cancer, TNBC, it is nice to upfront try and do molecular profiling just to increase your option as to how to treat the patient. However, if that is not possible on progression, I strongly recommend, if not one of those big fancy panels, at least do a small, well-validated panel looking out for all the possible resistance mutations. There are enough data, due to paucity of time, I've not been able to talk about the different platforms in liquid biopsy, which actually show that liquid biopsy is a reliable, like the plasma match trial, for example, is a reliable platform for testing in the realm of breast cancer. So molecular profiling is recommended, at least at progression, if not upfront, in a metastatic case. Next, please. And then on that note, thank you very much for your kind patience and listening.
Thank you so much, ma'am. If you have any questions for the session, we welcome the same, and we'll request Aparna ma'am to take the questions.
Sure.
So I don't think we have any questions. So thank you so much, ma'am. I'll now request our program director to please give the closing remarks. Over to you, Manoj sir.
Thank you, ma'am, for a wonderful session. I would like to thank, first of all, I would like to thank everyone, like who is on Randeep sir, Purvish sir, Hemant Malhotra sir, Talati sir, and Bapna sir, Somani sir. Almost everybody has contributed, all the respected senior, all the colleagues, sponsors. Kavina has done a great job. Sponsors, everybody has their own strength and has supported the event fantastically. So this was a journey of from clinical chemotherapy aspects to going to the molecular targets, and now we are targeting all the specific subsets and changing the survival curves. So I feel proud to be a part of MOSCON team, and I have contributed in terms of
Manoj sir, are you there, sir? So you'll have to unmute your mic, sir.
Okay. So we have changed the current concepts of understanding of the cancer and current practices in terms of the treatment. Few of the practices will be like starting from tomorrow onwards, Monday morning clinic. Some of them we have to wait for generating more data, more evidence, then we can practice. But to look forward, this is the future and this is going to be here. Thank you. Thank you, everyone.